welcome to the CTX Alliance annual meeting at the ULF conference. For those of you who don't know me, my name is Jean Pickford, and I am the executive director of the organization. I'll be introducing Andrea in a second. I just want to go over the agenda. It's been on our website, but hopefully you had a chance to see it, but it has changed a couple times. So we're going to start off with Dr. Duell, going to be talking about introduction to genetic cause and clinical signs, then followed by Dr. DeBarber, and then Bart's going to come back up and he's going to talk about the results from the RESTORE study. We have two remote speakers who will be joining us, Dr. Nobrega and Dr. Saute. Oops. Sorry. And then we're going to have some Q&A, and there'll be a short break in case anybody has to go to the bathroom or wants to, stretch their legs. And then we'll come back, and at 3:20, Dr. Steiner is presenting two presentations. Then Abbey, mother to two children with CTX, will be coming on and talking about her perspective on a registry. Then we have Dr. Jennifer Rossen, who's coming and talking about an ophthalmology project. And then you'll follow up with me talking about the CTX Alliance. And then we have a short little celebration at the end. So I am going, Andrea, would you like to say a few words before Bart starts?
Yes, I just wanted to say welcome everyone. Thanks so much to all the great speakers that we have today. Thank you for participating. Thanks to everyone for coming today and participating in the meeting. We had a great start yesterday with the ULF scientific meeting. We had a wonderful talk on CTX given by Dr. Yeda Lee, who's here today. So that was a great start, and I'm very excited about this family and scientific session this afternoon. So welcome everyone, and we'll start with Dr. Duell. Thanks, Bart.
So I'm Bart Duell, and let me see if we can go to the slides. Okay, so I'm Bart Duell, and I'm so pleased to be here to speak to all of you, and thank you for coming to this session on CTX. I think all of the speakers are very excited to be part of this and transmit the information to you that we hope will be very helpful. So my task in this opening presentation is to just give an overview of CTX, and I'm going to give some detail that might be beyond what you want to know or might comprehend, but my goal is just to let you know the way we think about this and give you sort of the depth of how we think about CTX. I have a few disclosures indicated here, and this seems to have a mind of its own. It wants to keep going backwards. So I thought I would start with one of my patients, and I think I'm going to stand up here so I can see the slides better. So this is a guy who came to see me when he was 8 years old. He had a lot of different symptoms, and some of you can relate to these, I suspect. So he had difficulty processing auditory information. He could listen but couldn't put it into practice. Had chronic diarrhea since infancy. His body weight was below average. He had delayed motor development starting after age 3, so he was normal up to age 3 and then started to go downhill. He walked at 1.5 years, but then once he got a little older, he was no longer able to keep up with his brothers, his older brothers. And I'm telling you, I'm not pushing the button. It just keeps going. So this is vexed in some way. He started getting an unstable gait, unable to balance on one foot, and he developed bilateral cataracts as well. So with these various symptoms, he saw a lot of different doctors, and he was told, we don't know what that is. Maybe it's genetic. He even saw specialists of different kinds, and nobody really knew what was going on. But to his good fortune, he developed cataracts, and this was at the time that a big study was being done to screen for CTX in patients with cataracts. And we didn't have the study going yet at our site, but we had informed his ophthalmologist about the study, and she saw him and said, hey, could this be CTX? And so we did the screening, but he also had these characteristic cataracts. These weren't like old age cataracts. It was a diffuse kind of stippling behind his behind the lens. But in any case, we did the testing, and I'm being a little silly here asking what's his diagnosis, because of course it's CTX. And he had the standard testing with the cholesterol measurement. And so after all these years, 5 years of the parents struggling, going to various specialists, a simple blood test actually led to the diagnosis. And so I won't give you the rest of his history, but I'll just summarize to tell you that he went on treatment. This is now years ago, and he's a normal guy. His school performance improved. He can run and do normal activities, and so he's turned into a normal kid. And he has the good fortune of it only taking 5 years to get a diagnosis. Average is more like 16 years or 18 years from the onset of symptoms. And so for all of us who deal with CTX, one of the important goals is to try to find ways to shorten that time span. It really shouldn't take even 5 years to figure out what the diagnosis is, but that's the reality we're dealing with. So in terms of the symptoms, not everybody has all of these, but in infancy there can be diarrhea, failure to thrive, bilirubin levels can go up. Bilirubin is a product of breakdown of red blood cells that's produced by the liver. Cataracts are very common, as I'll show you in one of the upcoming slides. Many people, most people get cataracts with CTX. And then psychomotor retardation, what does that mean? It means the muscle function, coordination, all of these things can be impaired. And the cerebellum also is what helps coordinate movement. The cerebellum is what allows me to close my eyes and reach and touch my nose. It helps me coordinate all of those movements, and if that gets disrupted, it becomes difficult to walk and move and control our actions. I think this is just trying to speed me up. It's enough on that slide. Go to the next. So in adulthood, things get worse, and I do want to emphasize this natural history is really without treatment. So once the treatment is started, then the underlying condition is fixed as much as possible, and so progression in many cases will stop. In some cases it keeps going for reasons we don't understand. So I want you to understand that this list is not a guarantee. For the case I presented of the young boy, I'm anticipating he won't get any of these conditions. So they can get the ataxia, which is sort of irregular movement, spasticity, meaning muscle cramps and things. Gene, I don't...
There's a PowerPoint setting that the timer must be on in the PowerPoint setting.
It's, yeah, I have some spasticity maybe. So the intellectual disability, dementia can occur, and sometimes this is subtle, but again, with treatment, then that effect tends to be blocked. And psychiatric symptoms can occur, and these are not always predictable, but some of it's related to the underlying condition, some of it's related to just dysfunction of the brain. Processing of emotions and other things can be a problem. Cataracts, I talked about. Xanthomas are big bumps, developments in the tendons. They can occur in the brain, also in the cerebellum specifically. And then early onset of heart disease, the chronic diarrhea, seizures, that's related to impairment of brain function. And then osteoporosis, I have to say, I don't fully understand, but some of that may be related to the malabsorption due to the chronic diarrhea leading to abnormal bone health. Okay, so this is a very nice figure. This is from Dr. Steiner and the late Jerry Salin, one of the pioneers in the field of CTX. And it's a nice chart showing the different symptoms on the far left over here. And then here's age on the what would be the equivalent of the x-axis, showing that chronic diarrhea starts early. Some of these other things start early, cataracts that I've mentioned. And then other things like xanthomas occur later in life, and then more severe problems with dementia or brain dysfunction tend to occur later in life. So I emphasize one more time, though, that if we can start treatment back here, then we can X out a lot of this other stuff by implementing early treatment. It's never too late, though. So many people improve a lot and can have some regression of the symptoms, but earlier is better, of course. So what about the biochemistry? This is the part that might stress you a little bit, but my gosh, this just won't quit. It's a recessive disorder, so that means you get one abnormal gene from mom and one from dad. And this will entertain you at least. One abnormal gene from each parent, and then it's caused by what's referred to as biallelic pathogenic variants. So the new terminology for, quote, mutation is to call it a pathogenic variant. Part of the reason for that is that there are lots of things that cause a condition that aren't really a mutation. It's a mutation implies you're a mutant. So pathogenic variant's the preferred term. And then biallelic, alleles are the companions on the two different genes that we have. For chromosomes, for every gene, there's one on each chromosome. So it means each gene is affected. That means if you're a carrier, you don't have CTX, although we have some biochemical data saying there might be some subtle abnormalities there. And then the defect in this gene, CYP27A1, it encodes this enzyme, sterol 27 hydroxylase. And I assure you, if you ask your physician what's sterol 27 hydroxylase, most will say, I have no idea. So if you think this is just common language for doctors, it is not. This is for geneticists and others. So a defect in that enzyme, though, causes defective bile acid synthesis, and I'll say more about that in the next slide. We've talked about all of these other things. So this pathway I'm showing you not because I think you'll remember it, but in case you want to look at it later, I think the slides will be available. Is that right, Jean?
Yeah.
Yeah, and so basically this enzyme is involved in the standard pathway, the classic pathway for bile acid synthesis, and then this alternate pathway. And the important point is that it blocks this enzyme that's down here in the final step of producing these bile acids. And so bile acids are critical for functioning in the gut. Without bile acids, it's hard to absorb fat. And if you don't absorb fat, you have diarrhea, and hence you have the condition of chronic diarrhea. In addition, if you have diarrhea, you're not absorbing nutrients, so that can cause growth delay and other abnormalities in development. It might even affect brain development if you're not getting adequate nutrition. So a very, in theory, simple defect, a block in bile acid synthesis, causes all these myriad symptoms affecting the brain and tendons and muscle function and all of these things. Okay, we talked about cataracts. I want to mention that again, that onset of bilateral cataracts causes a 500-fold increase in the odds of having CTX compared to the general population. So I don't know what proportion of ophthalmologists understand this, but for every ophthalmologist at our institution, I think they're well aware of this, and so it's a strong clue to say, okay, this child needs to be screened for CTX. And then the xanthomas shown here are, this is starting to be a little bit fun, but this thing has a mind of its own. The xanthomas shown here are quite dramatic, and many people do not get xanthomas this big, but they are very common, and they're very dramatic. And in the discussion of the delay in diagnosis, I'll mention to you that one of my colleagues in New York recently gave a lecture on another rare disorder, homozygous familial hypercholesterolemia. And homozygous FH causes very high cholesterol levels, and it causes big xanthomas like this. And so my colleague gave a lecture on homozygous FH, and a physician in the audience came up and said, I have those. I have xanthomas like that, but I don't have high cholesterol. And so here's a physician who had this abnormality, and he's obviously an adult in his 40s, and ended up having CTX and had no awareness of it. Okay, so big xanthomas can occur. Once treatment is started, these don't go away very quickly. They might over 20 or 30 years. But any of you who've ever injured a tendon, you know that it takes a long time to heal. And so the blood supply is not very good, so they don't regress very quickly. Xanthomas occur in the brain, as I mentioned earlier, and these white areas here are basically deposits in the brain that are similar to what you saw in the tendons. And these contribute to the dysfunction of brain function and also can cause seizures as well. And then osteoporosis I mentioned earlier, and this is actually the leg of the young boy with CTX. He had a fracture not because of osteoporosis. He had a fracture because he's a young boy, and he did young boy things that contributed to this injury. So in any case, we published this article a number of years ago with Dr. Schaefer and Dr. Salin and others, and it showed that the mean age of diagnosis among these 43 cases of CTX that we reviewed was 32 years. Okay. 32 years. The follow-up of these patients we had was for 8 years. Chronic diarrhea, cognitive impairment, you can see these were all very common conditions, including cataracts that were seen in 70% of people. Prevalence is pretty uncommon, 3 to 5 per 100,000 individuals. It's higher in some populations where there's a founder effect, like the Druze in Israel or Sephardic Jews. And then I mentioned this earlier, that among people with childhood onset of cataracts, the prevalence of CTX may be almost 2%, 1 or 2%. So you go from super rare to very common. Diagnosis is made on the basis of cholesterol measurements in the blood. There are, as we know now, cases of CTX with normal cholesterol, and I think, Andrea, you'll be talking about that. Genetic testing can be done. We can do blood spot testing. This is part of the basis for trying to add it to newborn screening. I'll skip this, and I'm being told I'm out of time. You'll see all this from Dr. DeBarber in the next talk. Treatment is, hooray, there's a treatment, chenodeoxycholic acid. It's now FDA approved as of February of this year. And earlier treatment's better, but it's never too late. Getting on treatment as soon as you can is important. Monitoring is something we recommend here, and I think Andrea will talk about that more later. Other treatments might be needed, but these are sort of basic for regular medical care. So nothing unique to CTX about this, but depending on what kind of complications have occurred, other treatments may be necessary. And then I want to emphasize these at the bottom. Eat healthy foods, get regular exercise, don't smoke, be good to yourself, try to get enough sleep, all of those things. So the summary is indicated here. The disease is caused quite simply by biallelic mutations or pathogenic variants in this gene, CYP27A1. The consequences are all the things we've talked about, and then in bold at the bottom, early diagnosis, early treatment are essential. So with that, I'll quit. Thank you for your attention. I think I've gone 1 or 2 minutes over time. So we'll pass it on to...
Want to switch the lavalier mic to Andrea?
Okay, that's better. So let's see if this will work for me now. And we will have some time at the end for questions, so please save your questions till the end. And thank you for that wonderful introduction, Bart, for CTX overview. So my name is Andrea DeBarber. I'm from Oregon Health and Science University as well. Here's my conflict of interest statement. So I'm going to kind of digress a little bit and talk about another problem that we have in CTX, and this is the underdiagnosis and late diagnosis of the disease. So CTX patients as a group are likely very underdiagnosed. So generally those who are eventually identified with CTX often go undiagnosed for more than 10 to 20 years after onset of initial symptoms, as we can attest to for many of the patients and families here today, which can result in a significant burden of often irreversible neurological disease if the treatment is too late. So tools to mitigate underdiagnosis and late diagnosis include a greater disease awareness by the physicians, and this is something the CTX Alliance has been working on. Good genetic testing that can provide a result, good biochemical testing for a biochemical diagnosis, and of course newborn screening, which is something else that the CTX Alliance has been working on. So in terms of genetic testing, as Dr. Duell mentioned, CTX biallelic, pathogenic or lightly pathogenic variants in the CYP27A1 gene can confirm a diagnosis of CTX. So there is a bit of a problem with genetic testing. So there are around 694 known variants in the CYP27A1 gene. However, 263 of them are classified as variants of unknown significance. And that means if this comes up on a genetic report, especially if there's 2 of them or 2 different ones or 2 the same, that means that the genetic test result can't provide a definitive diagnosis of CTX. So that can be a problem with genetic testing. So if you have these VUSs, okay, so here we go, it's giving me a problem now. This can lead to an uncertain genetic test report and a potential misdiagnosis of CTX. So that brings me to the biochemical testing. So sometimes that can be really useful in these indeterminate kind of genetic results. So Dr. Jerry Salen, that Dr. Duell mentioned, back in the early 70s, proposed that a biochemical diagnosis of CTX could be established through measurement of elevated plasma cholesterol. And so for just over the last 50 years, this has been used as the primary biochemical diagnostic test for CTX. And conversely, identification of a normal cholesterol level has been considered definitive for excluding CTX. So if they sent the biochemical blood test for a test for cholesterol and it was normal, that would exclude a diagnosis of CTX. And so normal cholesterol we measure to be around 5.4 milligrams per litre. And so I'm coming back to the pathway that Dr. Duell showed. So the deficiency in CTX is a deficiency in the CYP27A1 or sterol 27 hydroxylase enzyme that's shown here. And this is important in the pathway, the main pathway to the bile acids, primary bile acids, chenodeoxycholic acid and cholic acid.
And so in CTX, there are low levels of particularly chenodeoxycholic acid, but cholic acid as well. And normally, these act as ligands to what's called the FXR or farnesoid X receptor, which basically shuts down the first step in the bile acid synthesis pathway, which is shown here. And this is the conversion of cholesterol, the 7-alpha hydroxylation of cholesterol. So in CTX, when you have a blockage in this pathway and you have low levels of chenodeoxycholic acid and cholic acid and very high levels of this first step in the bile acid pathway, it means that all of these bile acid pathway intermediates shown in grey accumulate to very high levels. And you can see cholestanol is slightly off from this pathway. It's formed from a molecule that we called 7-alpha hydroxy 4-cholestin-3-one or 7-alpha C4. And then there's other bile acid precursors. There's another 12-alpha hydroxylation to form the 7-alpha 12-alpha C4. And then this gets further converted into bile alcohols. And so bile tetrols with 4 hydroxy groups are very high levels in the blood, and they're used as a blood biomarker for CTX. They can add another hydroxy group to form bile pentols and another one to form bile hexols, and these are excreted at very high levels in the urine. And so typically my lab at RHSU and other labs like Dr. Setchell's lab at Cincinnati Children's Hospital have set up biochemical diagnostic testing. And at RHSU we measure cholestanol, and you can see the top row are kind of like the normal levels of these biomarkers. And then we have set up quantitative tests to measure the other biomarkers that are more directly in that pathway. So we measure 7-alpha C4, 7-alpha 12-alpha C4, bile tetrol in the plasma, and then bile pentol in the urine. And as I said, the normal levels at the top and the levels that we normally see in untreated CTX are shown on the bottom row. So cholestanol on average is about 10 times higher in CTX, and that can be useful, as I said, for a diagnosis of CTX. But some of these other biomarkers, like the bile acid precursors or the bile alcohols, are at extremely high levels, so hundreds to thousands times higher in untreated CTX. So this is what we typically see in patients who have high cholestanol levels, so high cholestanol about 10 times normal. And all of these patients would have been picked up using testing for cholestanol because their cholestanol is high. But today I just want to talk about some other cases that we've seen at RHSU and in our collaboration with other physicians. So this is one of Dr. Duell's cases. And so this is a 46-year-old male who had a history of these large tendon xanthomas. You can see here on the right on the knuckles of the hand and the Achilles tendon. But over many years, the plasma cholestanol remained normal in this patient.
Yeah. Should we fix that? I think if we just go to PowerPoint and go to the slideshow and there to do manual.
Really sensitive, so I would just keep your hand on the.
Might I suggest you just put it right there, and then when they want to hit the slide, you hit it.
Okay, we'll give that one a try. And so over many years, this patient continued to have normal cholestanol, and CTX was ruled out as a diagnosis. So fast forward about 30 or 40 years, the xanthomas first became apparent at around 33 years old. And fast forward now, there was a myocardial infarction, a heart attack, and a stroke to 83 years old. And at 86 years old, so almost 40 years later, the patient had genetic testing that actually confirmed a diagnosis of CTX. And so we went back and we went and looked at these other biomarkers, the bile acid precursors and the bile alcohols, and we were able to show that yes, they were actually elevated even though the cholestanol was normal. So there was another patient that was born in India, a 65-year-old male, also who had a 38-year history of these large Achilles tendons on the tendon xanthomas. And beginning at age 64 years, the patient developed vertigo, memory loss, gait alterations, and difficulty in walking and balance, and difficulties with swallowing. He was seen by a neurologist and given the diagnosis of progressive pseudobulbar palsy and ataxia. Okay, I wasn't even touching it then, so, okay. He was seen by a neurologist, and again, the suspicion of CTX came into play here, but the plasma cholestanol concentration was normal. So genetic testing was performed, and the genetic testing did confirm the 2 pathogenic variants in the CYP27A1 gene, and we performed the biochemical testing, and yes, a normal plasma cholestanol, but the other bile acid precursors and bile alcohols were elevated in this patient, so we were able to biochemically confirm the diagnosis of CTX. And then this was the 3rd case of a 40-year-old female who had these xanthomas that you can see here on the elbow. The patient's sister had similar tuberous xanthomas on her knees. She was told these were keloids until a skin biopsy at 39 years old identified xanthomas. But again, the plasma cholestanol concentration was normal. And so again, genetic testing was helpful in identifying CTX. And we performed the biochemical testing, and again, totally normal plasma cholestanol, but markedly elevated bile acid precursors and bile alcohols. And so we're getting a new understanding of CTX, that there is a broader spectrum of the biochemistry than was always thought for the last 50 years when people have used cholestanol as the primary biomarker. And we can see in these 3 patients, we show the average concentrations at the bottom, so the cholestanol remains around 3.2 normal, but the other biomarkers are markedly elevated and can be helpful for a biochemical diagnosis in these patients. So this milder biochemical form of CTX, and when I say milder biochemical, that doesn't mean milder clinically. These patients suffered clinically, from severe symptoms as well, like classical CTX, but they just have a slightly different biochemical presentations. This really represents a diagnostic.
It's in the same receiver signal, so just look at me and I'll hit your next slide.
Okay, perfect. This represents a diagnostic challenge for a disorder for which cholestanol has always been believed to be a sensitive biomarker. And these cases demonstrate that measurement of plasma cholesterol alone is insufficient to exclude a diagnosis of CTX. And that these biomarkers that we've started to use now provide a sensitive biochemical diagnostic confirmation even in a normal cholestanol CTX patient. And as Dr. Duell said, the important thing is trying to diagnose patients earlier, because then they can get on treatment and we can prevent, all the outcomes that we would not want to see. And, this is very important. I just wanted to come back to this, the case 2 that I talked about, because very unfortunately, finally a diagnosis was provided at 65 years old. The patient was started on chenodeoxycholic acid, but very unfortunately died due to the complications of the progression of the disease. So we really want, move the slide forward please. We really want to identify more patients, and as I said, my lab's been working on improved testing to help with these patients, especially for patients that fall into this grey area with indeterminate genetic testing and these VUS results and normal cholestanol. These biomarkers that we're using can be extremely helpful to provide biochemical diagnostic confirmation. And I wanted to talk about this sponsored program. So if you have any questions about this, please feel free to email me. But Miriam sponsors a testing program to if there's a suspicion of CTX, for physicians and patients to send the samples to our lab and get this testing performed. This is called the SCOUT program, and I'm going to speed it up a little bit here, but just to say that these biomarkers are also useful for monitoring treatment in these patients with normal cholestanol, because obviously the cholesterol is normal, so it doesn't go down on treatment, it stays the same, but the other biomarkers go down. And the sponsored testing program for new patients that are identified performs testing at baseline at 1, 6 and 12 months after a patient goes on treatment. So we can watch the biomarkers go down and make sure that the treatment is effective at normalizing the atypical pathway that we see in CTX. Okay, so I'd just like to acknowledge all my co-authors on this, the folks in my lab, Dr. Connor and Sonia Connor at OHSU. As you see, Dr. Duell heads up the lab at OHSU, the testing lab as well, and to all the folks at Miriam Pharmaceuticals for helping enable us to provide this testing and access to this biochemical testing to diagnose more CTX patients. So I'll finish up there.
Non-functional? Okay, yeah, it works. Great. So I'm Bart Duell. Nice to meet all of you. No, thank you, Andrea, for the great lecture and presentation. And I know some of the biochemistry from that might feel a little bit obscure to you. I would say for many physicians, it's quite obscure as well. And so there's a steep learning curve here for all the doctors. So that's why we keep publishing things, trying to educate different doctors about the tests that are available and how best to diagnose the condition. So this next talk is about the RESTORE study. And this was really a and I'm holding this. We're not ready to go on yet. Well, that's fine. You can go to the next slide. So the RESTORE study was really a landmark study because it was the first randomized placebo-controlled study done in CTX. And one of the daunting things about this is to do a study in CTX. The ideal study is where you give a placebo or the real treatment, and then you follow people for some period of time to look for outcomes. And so for preventing heart disease, for example, early trials put people on placebo treatment for 5 years or 6 years. People with heart disease, they'd had a heart attack, they went on placebo for 5 or 6 years. That meant people died. They had complications from being on placebo. And so in CTX, if I ask, I won't have you raise hands, but if I ask anybody with CTX, do you want to go on placebo for a year or two to find out if the treatment's helping you? The answer is no. And any specialist who treats patients with CTX, if you ask, will you put your patient on a placebo? They all say no. And so that was the huge barrier. But the FDA wanted a study, a placebo-controlled study, showing that treatment actually made a difference. So this is a very cleverly done study that minimized patient risk, but actually generated excellent data. So I can skip through these first ones, I think. This is just a reiteration of what I said earlier, talking about the chronicity of the condition, how side effects develop over time, and so we want to diagnose early. Next slide talks about goals and strategies, and I think this is going to come up more toward the end of talking about what to do going forward. The early diagnosis obviously is important, and how to make that happen is tough. Newborn screening I put in bold because that has the most potential. Everyone thinks artificial intelligence can do anything and everything. In medicine, especially for a disorder like CTX, it might be helpful, but I have my doubts about that. I don't know if Dr. Steiner has a different opinion about that, but we'll move on from that. And then the next slide talks about chenodeoxycholic acid therapy. I added that cholic acid might be helpful in some cases. I think there's some debate going on about that. And then next, talking about gene therapy, that's way beyond the scope of this talk. So next slide. So chenodeoxycholic acid, it's been the standard of care for decades, 40 years. And early on, we had to order it from the United Kingdom or get it from different places. It's been a long and difficult course. But over years, the goal was to try to get FDA approval for CTX treatment. And through discussions with the FDA, this RESTORE study was designed. And then the outcome of this, sort of jumping ahead to the punchline, is that the drug Duell was FDA approved in February. So that's a very exciting step moving forward. But next slide shows the design of the study. And so the way this is, there were 14 patients recruited, and there was an open label period. About half of these people weren't on treatment yet, so they were kind of already on placebo, so to speak. Half were already on treatment, and so they had to go off treatment. And this was set up for a total of 2 months off treatment. So that was deemed to be minimal risk. I think there was a lot of anxiety for the patients doing this, because who wants to take a chance? But it was set up to have careful monitoring, biochemical monitoring, as I'll show you, going on placebo or treatment for 4 weeks, then back on treatment for 2 months, and then another 4-week period. And let's see, next slide, please. Yeah, so this is the rescue therapy, basically. If patients developed symptoms, whatever they were, if there were worrisome symptoms, then patients could go back on treatment during the blinded period, or if the biochemical results were very abnormal, then treatment was reinitiated. So again, this minimized risk to the patients, but maximize the possible outcome from a placebo-controlled trial. So my hat is off, so to speak, to Miriam for designing this and actually developing a study that generated meaningful results without harming anybody. It's a major accomplishment. So next slide shows what you've seen before. And the reason to point this out is that all of these things that are elevated were monitored, excuse me, all of these things were monitored during this study. And so just to remind you, these are intermediates in these pathways that are abnormally elevated in CTX. Next slide, please. The primary endpoint was changes in 23S-pentyl bioalcohols. So if you go back one slide, up here are the bioalcohols. And these respond probably most quickly of all of the biochemical parameters. And so that was the reason it's the primary outcome. And then next slide, please. And then the secondary endpoints were all of these other biomarkers that you heard Dr. DeBarber talk about. And then changes in plasma bioalcohols were examined as well. To be in the study, there's a separate study looking at kids, but it was considered a study in adults, but if you were 16 or older, you could be in the study. That was considered adult from the standpoint of the FDA. And they had to, of course, have CTX. So next slide. So I'm going to show you a series of slides, and you'll find they're quite monotonous. The data are strikingly positive. So what's shown here is the baseline results, and then this is open label treatment. Everybody got treatment. Here's the placebo phase, this shaded bar of 4 weeks, and then here's open label treatment, and then back on placebo or the real thing. And so the red line is the people who were on placebo here, and then the green line is people on placebo during this period. And then the reasons the numbers drop here is that, as I said, about half of people weren't on treatment at baseline. So they went on treatment, it worked. It brought down the level of the pentyls, the bioalcohols. So in many studies, many clinical trials, the changes in the results are small, and you need to do statistical analyses to show whether it's meaningful or not. And so this is obvious and dramatic, very dramatic and quite impressive. In fact, I was surprised with the rapidity of the change, and think many of us were actually surprised how dramatic this was. But in any case, you can see a massive increase. So the levels were quite low here and then went up to 40,000. Once treatment was resumed, then within a couple of weeks, a few weeks, the levels were back down to baseline. So this is, to me, very exciting, showing just for clinical management that if you forget to take your medicine for a few weeks, as indicated here, or even if you're off just for 1 week, the levels can go up 10-fold or maybe 20-fold even. Okay, so this is the first slide, looking at bile alcohols. And then next slide, please. Yeah, so yes. So this is the cholesterol levels. And the cholesterol levels, once we start treatment, for somebody who's not been on treatment, it takes months and months for them to come down to normal. And part of the reason for that is that cholesterol accumulates all over in the brain, in the tendons, and other tissues. It takes a long time to mobilize that. But in this study, for people who had controlled levels, that means once the levels started going up, it was accumulating primarily in the blood. There wasn't enough time for it to deposit everywhere else. And so once treatment was started again, then it plummeted back down to the normal range again. So, and then in this placebo-controlled period, these are the ones in green who were on placebo, showing a massive increase. So, and again, it's quite dramatic change. Here the level is around 2, and then it went up to 15. So 7-fold increase in just 1 month. Okay. Next slide shows the 7-alpha-C4 levels. And basically, we could just change the title, and it's the same thing. Very dramatic. Next one shows 7-alpha-12-alpha-C4. Dramatic changes like the last one. Next slide shows the plasma bile alcohol levels. And so, I mean, for Dr. DeBarber and myself, these data were very exciting as well as validation of the impact and the meaning of this biochemical testing that we've been doing. Next slide shows all of these graphs together and just emphasizes that quite incredible data, so showing massive increases in the biochemical results, dramatic drop very quickly within 2 or 3 weeks after resuming treatment. And it was this data then that, we can go to the next slide, led to the FDA approval. This data is a little harder to quantify, but it shows the number of patients who needed rescue, either because their lab results went up or they had symptoms. And the data are quite obvious. Here's the pooled data showing 2/3 needed rescue on placebo, even though it was only 1 month off treatment, and then 8% who were not on treatment. Next slide, please. And I'm being told I have to hurry. So the side effects, these are kind of confusing because diarrhea is a symptom of CTX and it gets better with treatment. This shows the similar rates of diarrhea on placebo or on treatment. I think that's part of the, basically related to the study design, and it says nothing about whether this treatment reduces diarrhea or not. And then constipation, the opposite of diarrhea, appeared to be more common on placebo, which is the opposite of what you'd predict. So I'd say these side effect profiles are kind of confusing. And then headache was the same for both. Next slide. And the next slide, I put in here just for completeness. This is the kind of stuff physicians have to look at who are going to prescribe the drug. It's not important to you, but this is the kind of detail that physicians get. And it says at the top, hepatotoxicity. That's actually, I'll be blunt and just say that's misplaced. So that's based on data where people who have adequate bile acid levels are given chenodeoxycholic acid, and there can be hepatotoxicity. In CTX, we're replacing what's missing, and so it's a totally different situation. Next slide. We can skip that. So the key takeaways are, as we've been emphasizing, early diagnosis and treatment are important and are very likely to prevent long-term and irreversible outcomes. Fortunately, on the basis of the RESTORE trial and the dramatic results that convinced the FDA to approve chenodeoxycholic acid for treatment of CTX. So it's a new world in that regard. I have a couple other slides, but I think I'll quit for the sake of time. So thank you for your attention.
Our first remote speaker. This is Dr. Nobrega. He is going to join us via Zoom.
Is the audio okay? Can you hear me?
I can hear you. We're just pulling up your slides. You sound great.
Okay.
Okay, you're on the floor and you can start. Thank you for joining us.
Okay, thank you very much. I'd like to thank the CTX Alliance for inviting me today. I'm a professor of neurology in Brazil, and it's great coming after Dr. DeBarber and Dr. Duell, because I think they already said most of what I was going to say today, so thank you very much for that. I'm going to talk about exploring the diverse clinical spectrum of CTX. This is my outline. I'm going to talk about neurological manifestations mainly, especially the ones we have been recently working on. Dr. DeBarber already talked brilliantly about the metabolic defect in CTX. So we know CTX is a multi-system metabolic disease related to bioacid metabolism disorder, and it has multiple neurological manifestations with a varied age of onset. We have non-neurological manifestations. These have been shown here. We have chronic diarrhea, cataracts, and xanthomas as the main non-neurological manifestations. And we also have many neurological manifestations. So for a neurologist, CTX is like reading a book on neurology, because you can have cognitive impairment, psychiatric symptoms, ataxia, spastic paraplegia, neuropathy, sleep disorders, and even other movement disorders than ataxia. We see here, this is a graph from our study, our Brazilian cohort of 38 patients, where we see the most prevalent symptoms being cognitive impairment, psychiatric symptoms, spastic paraplegia, and ataxia. This is similar to what was shown by Dr. Duell, and this is similar to most other cohort studies previously published, with cognitive decline, psychiatric symptoms, ataxia, and spasticity being the most prevalent neurological symptoms. As we can see here, the age of onset for each of those neurological symptoms can vary. We have intellectual disability usually presenting in childhood. Xanthomas usually present around the age of 20 to 30 years. And we have cerebral ataxia, usually around 20 years, neuropathy around 20 years. And we have dementia, usually presented after the age of 50. And some authors have suggested that we may have a spinal subtype of CTX. It's a clinical type where spasticity predominates. And these cases probably have a later symptom onset around the age of 30 years. This is another graph from our cohort where we show that although we have mean age at presentation for each of these symptoms, we have a wide range of age of onset. So we can have cataracts presenting after the age of 30. We can have ataxia presenting after the age of 50 years. And this is to remind us that if we have a patient with late onset neurological symptoms, we still must think on CTX as a possible diagnosis. And this is a Kaplan-Meier graph. What we show here is the age where the patient develops each of these symptoms. So we see that around the age of 30 years, which is here, almost half of patients have almost half of non-neurological manifestations. And what I'm trying to show here is that if you see a CTX patient with around 30 years of age, he will have probably simultaneously multiple neurological manifestations that sometimes can be confusing for the clinician or for the general neurologist. We have studied neuropathy in CTX. Neuropathy, which is a disease of the peripheral nerves, seems to be common and disabling. It affects 50 to 77% of patients with CTX. So most patients have neuropathy, and most patients can present with changes in nerve conduction studies, which is a study conducted to assess nerve function, even before they have clinical symptoms suggestive of neuropathy. And also, these cases are not so easy to diagnose based on electrophysiology, because there has been a debate whether neuropathy is demyelinating or axonal, whether neuropathy predominantly affects myelin or the neuronal axonion. So the first report of neuropathy in CTX, one of the first reports dates from 1986, and they have studied neuropathy and shown that it's mainly a demyelinating neuropathy with onion bulb formation. These structures here are very suggestive of a primary myelin involvement. But again, after that, a group by Paulo de la Fuente have studied many patients with CTX and neuropathy, and he's shown that some patients have predominantly demyelinating neuropathy, while others have predominantly axonal neuropathy. So we have recently reviewed neuropathy in CTX, and what we came to believe is that neuropathy is primarily demyelinating, because most recent papers describe neuropathy as demyelinating. The recent papers with nerve biopsy show demyelinating findings, like onion bulb formations, which we see here. And in our Brazilian cohorts, all patients had demyelinating neuropathy. And why is this important? Because we are trying to use nerve ultrasound as a diagnostic tool for CTX. Nerve ultrasound is non-invasive, and it has been used for other forms of hereditary neuropathies in the past. And in demyelinating neuropathy, you usually see nerve enlargement, which is easily detectable by ultrasound. So Lee et al. Described in 2017 one patient with bilateral xanthomas and a demyelinating polyneuropathy. This is the picture of the xanthomas, typical. And what they've seen is thickening of peripheral nerves in these patients, which they suggest is related to cholestanol deposition on peripheral nerves. And they also suggest that when seeing a patient with xanthomas, if you have an ultrasound, you could perform nerve ultrasound. And if you see nerve thickening with xanthomas, the diagnosis is probably cerebrotendinous xanthomatosis, even before symptoms of neuropathy appear. This is the nerve cross-section area. This is the area of the nerve in this patient. Compared to a normal control subject, you can see that in most nerves, it's more than double the nerve area from the normal subject. And then this study in 2018 has shown that you can detect on MRI hypertrophy of the lumbosacral nerve roots in CTX. And a somewhat larger study with 4 patients in 2020 also described nerve enlargement in CTX, suggesting that it is suggestive of cholestanol deposits. So again, you see enlarged nerves in all nerves studied. And what we are doing today, this is unpublished data, this is under review. We've studied 6 patients aged 9 to 46 years with a 50% prevalence of clinical symptoms of neuropathy, all of the demyelinating pattern. So you see here, this is a nerve conduction study, and you see in this last column that they have decreased conduction velocity under 50. It's usually decreased conduction velocity. showing a primarily demyelinating neuropathy. And what we've seen is nerve thickening in all nerves from all patients, even the patients who do not have clinical or electrophysiological neuropathy. And we've seen for the first time in the literature, thickening of the brachial plexus. So if you don't believe me, you can see here, this is a picture for a control patient. This is the brachial plexus, and this is from an asymptomatic CTX patient showing enlargement of the brachial plexus. So we've seen that 2 patients, even without symptoms and without nerve conduction abnormalities, had thickening of the peripheral nerves. All patients have peripheral nerve thickening. The number of xanthomas did not correlate with nerve thickening. We had patients without xanthomas and with nerve abnormalities, but the thickening of the plexus correlated with the severity of neuropathy and the severity of ataxia measured by specific scales. We then proposed the use of nerve ultrasound as a biomarker, a possible biomarker for disease monitoring and follow-up in CTX. We believe the larger studies are needed to conclude that this is indeed a helpful biomarker. And then we studied spastic paraplegia. Spastic paraplegia is a disease where you have increased muscle tone. It means your muscles are rigid, especially in the lower limbs. And we now know that spastic paraplegia is a common finding in CTX. Up to 50% of patients may present as spastic paraplegia. And a cohort study by Dr. Jonas, who is going to talk to you after me, has found that 10% of a cohort of spastic paraplegia in Brazil corresponded to CTX patients. So possibly CTX is a treatable form of spastic paraplegia. We are alerting neurologists that when they see a patient with spastic paraplegia, they have to screen for CTX, and gene panels for HSP or hereditary spastic paraplegia should include CTX as part of their analysis. And xanthomas may be absent in these patients at the time of presentation. So spastic paraplegia without xanthomas, we have to think of CTX. We have also studied sleep disorders in CTX. It was a small pilot study published in Sleep Medicine. We saw 4 patients with clinical evaluation, MRI, clinical scales, and we've conducted comprehensive sleep evaluation with polysomnography, wrist actigraphy, and some sleep-related questionnaires. Patients were aged 27 to 46 years, all adults, all had psychiatric symptoms, mainly anxiety, all had cerebral ataxia and variable degrees of other neurological manifestations. And what we have found is that excessive daytime sleepiness may be more common in CTX than in the general population. We've seen that in 75% of our patients. 1 patient had insomnia, and 1 patient had obstructive sleep apnea. As OSA is highly prevalent in the general population, we think this might be a coincidence. But the interesting finding from this study is that although it's a small study, what we have found is that all patients with sleep abnormalities also had cerebral or brainstem MRI abnormalities. And the only patient who had a normal MRI had no sleep complaints and no objective sleep findings. So we have suggested that sleep disturbances may be prevalent in CTX, and they may be related to cerebral and or brainstem dysfunction, but we acknowledge it's a very small study, only 4 patients. We think larger studies are required to draw any conclusions on that matter. And finally, we are studying cognition in CTX. Cognitive abnormalities are very prevalent in CTX, as Dr. Duell has mentioned, but up to 80% of patients have cognitive abnormalities with a variable age of onset, and we have to differentiate intellectual disability, which is a disorder of neurodevelopment, to dementia, which are patients who acquire neurocognitive functions and then lose them afterwards. Multiple tools have been used in the past to assess cognition in CTX, the mini-mental state examination, the MoCA, and neuropsychological assessments with IQ assessments. There's this interesting study from a French cohort with 9 children and 18 adults. which found 44% of children with cognitive impairment and 78%, almost 80% of adults with cognitive impairment. What's interesting about this study is that they followed up adults and they had repeat mini-mental examinations, and most patients did not experience cognitive decline. They have cognitive impairment, but did not experience decline. So dementia doesn't seem to be so common. Only 16% of patients in this study had dementia. And this great study by Dr. Duell with 43 patients treated with CDCA, he's saying that CDCA improves symptoms in 57% of patients, and most of these patients had cognitive impairment. Most of the patients with cognitive impairment improved after CDCA. We already know that late treatment is associated with worse cognition, but what I think we do not know is if a patient who has cognitive symptoms, who has dementia or cognitive impairment, if these established symptoms respond to CDCA, possibly, I think maybe they do not respond that well because maybe there's neurodegeneration already in place there. Andrea has talked about disease-specific biomarkers for CTX. They are really important. They were very important in the clinical trial. But what we are also studying now is neurodegeneration biomarkers in CTX. We are studying neurofilament light chain, which is a marker of axonal damage, and GFAP, a marker of astrocyte involvement. And we're also correlating this with ultrasound and MRI and clinical scales to try and find out if we can learn more about the process of neurodegeneration that started by cholesterol accumulation, but maybe goes on even after cholesterol is corrected, the biochemical defect. To finish, we have found out that we have no standardized neurological function scale for CTX. The disease has a wide disease spectrum, and we have used many scales to try to quantify neurological function. We've used the MRS, which is the modified ranking scale, the SERI scale for ataxia, the mini-mental scale for cognitive impairment, the SPRS or spastic paraplegia rating scale for spasticity. But we should ask ourselves if we should develop a scale to assess neurological function in CTX, or if we should continue using previously published scales depending on the phenotype. And what I think is that maybe developing a clinical rating scale for CTX would allow for standardized neurological function assessment, taking into account the wide disease spectrum, and allow accurate measure for follow-up treatment response, and maybe using future clinical trials. So to summarize, CTX is a multi-system disease with a wide spectrum of neurological symptoms. Neuropathy is common, although under-recognized. It's usually demyelinating with enlargement of nerves and plexi, and ultrasound may be a biomarker for that. CTX can present as a treatable form of HSP. Sleep disturbances may be prevalent in CTX, but we need larger studies to confirm that. Cognitive impairment is common. We have to differentiate intellectual disability, which is a disorder of neurodevelopment, from dementia, which is further worsening of neurological function. And biomarkers of neurodegeneration like NFL or GFAP may improve monitoring of disease progression and treatment response. Perhaps we should develop a clinical rating scale specific for CTX, and perhaps we need better patient-reported outcomes or PROMs for CTX. Thank you very much for having me. That was all. That's our group. Thank you very much.
Okay, thank you very much, Dr. Nobrega. We're going to pull in our next remote speaker. And keep in mind, we have an opportunity for questions. After Dr. Saute presents, we will have take questions from the Zoom chat and from the room.
I think it's okay now.
We can hear you. We're just waiting for your slides to pull up.
Yeah, I think I've done that. Did it work?
We're waiting for them to come up on our screen.
Hello, everyone. Can you hear me well? And can you see my screen?
Yeah, we can't see it here in the room, though, so just give us another second.
Okay.
Oh, now we can see you. Okay, we're ready. Thank you. You have the floor.
Ready? Okay. So I'd like to thank the CTX Alliance for inviting me to talk to you. I'm very happy also because of Paulo's presentation. It was quite nice also to hear some of these better descriptions of the neurological features of CTX. So my topic is about like breaking barriers, advancing global access to treatment. My name is Jonas. I am a neurologist and medical geneticist, professor in the Federal University of Rio Grande do Sul in South Brazil. This is a, I would say, hard topic to talk. I will tell some things to you, but I'd like to say in advance that perhaps my main message here is a question mark. So I'm not so sure on how can we advance that. I have some clues, and perhaps we might discuss that further on. These are my conflict of interest statements, and I was part of the Restore trial for CTX. So I'd like to start presenting also where I'm from. So the guys that were in Jerusalem 2 years ago, before we have the war happening, I also showed that, so likely you have seen it, but for the other ones, this might be new. So I'm located in Porto Alegre, which is the capital of the southernmost state in Brazil called Rio Grande do Sul. The city is around 1.5 million inhabitants. Our state's around 11 million inhabitants. And Brazil is a huge country, not so huge as the US, but almost. So we are around 214 million inhabitants. Our city, so we have this nice lake. This also happened after the Jerusalem meeting. So we have a flood in our city, a very bad one. So now we're not so proud of our river, but it's still a beautiful city. Soccer teams, you're also going to find some nice landscapes in Porto Alegre. And if you like to eat meat, this is a good place when you're going to find a nice barbecue. Okay, but you also have other dishes if you like. I'm located in Hospital de Clínicas de Porto Alegre. This is the picture of our hospital. My office is at the Medical Genetics Service, so I run a neurogenetics clinic there. And this is the only reference center for rare diseases in the state. We have 2 reference centers, but one of them is just starting. So most of the patients with this kind of diseases came to our center in Brazil. And this is the whole complex of the hospital. And we also have clinical buildings dedicated for clinical research. And this is where the CTX patients for the Restore trial were treated. Well, so coming back to Paulo's presentation, so I'd like to give Brazil as an example on how is the access of treatment for CTX. So we have this recent cohort. This was published in 2024 with 38 patients with CTX in the country. And in that cohort, 16, so a bit less than half of these patients were on treatment. And patients with specific treatment, all of them were with CDCA. So none of those patients were on cholic acid. 3 of these 16 patients discontinued treatment during time. 1 because of poor adherence, 1 because of hepatotoxicity, and 1 we don't know why, just know that the patient stopped during time. However, only 6 patients were on CDCA for more than one year in this study. I will explain why in just a moment. So I would say that a quarter or even less of those patients were on treatment in the country. And this population was mainly of patients with, I would say, late diagnosis. So the mean age was 32 years. The disease duration of these patients were around 22 years. So most of these patients have more than 20 years of disease onset. And most of them were not on treatment. So I would say the availability is not really good, or the access is not good across the country. And why only 6 patients were receiving for more than 1 year? The other ones, so the other, not 10 patients, because 3 has discontinued, but around 10 patients, they were receiving the treatment because of the Restore trial. So the clinical trial was also somehow an access to this therapy. But this was, so the trial started a bit earlier, the publication of this cohort. So we consider that these patients were receiving, since the treatment, it was considered at some time point they received this medication. But in general, most patients in the country were not on treatment. And I will tell a bit about the story of treatment I will just have to, let me put it here so I won't bother you in the screen. I don't think this is a nice story about the price of the medication, but this is related to why many patients were not on treatment in Brazil. And if we want to break barriers to provide access, price issues is something that we should be worried about, okay? So most of you are aware of that, but I will have to tell again this story. So this is from the story about in Europe, so Netherlands. So the CDCA was initially commercialized for the treatment of gallstones. The price was quite low at that time point. This was around the 70s and the beginning of the 80s. So the cost per patient per year was around 308 euros. Then when it was stopped to be used for gallstones, and it was started to be used mainly for CTX, the company, so at that time point was Sigma Tau, acquired the rights for the formulations available at that time point, and just by establishing the monopoly of the treatment, increased the price around 100 times. And then later on, in 2015, it was removed from the market to gallstone treatment, but then it was registered as an orphan drug for CTX. And then this license was provided in 2017. And this, although we didn't have a patent anymore, because this is a drug from the 1970s, they received market exclusivity because it was defined as an orphan drug, and this is until 2027. And this led to a 500 times increase in the price, considering the prices of the 1980s. This was something that were already discussing. So the trial, the Restore trial, was a possibility of access to treatments, to this treatment in Brazil. So because most of the patients were not on treatment, but the trial led to the FDA approval, which is one of the talks will be a celebration about the approval of this drug on the FDA. But you see that this like the registration in FDA and also some issues that happen also have some influence on having access or not to the drug in Brazil. So just tell also about the story. So Miro received FDA approval for, I don't know how to pronounce that, Ctexli, I don't know how. So CDCA from Miro was FDA approved in 2025. And they received, so this was a 7-year market exclusivity. So it seems to be until 2032. And the price, at least as what I got from the internet, is around $784,000 per year, which is even higher than the price in Europe. There is some issues regarding copay assistance. So patients that have insurance in the US, they might apply for that. So the insurance will pay a part of the treatment, and the patients just pay a really okay price to the treatment. But if they only have the Medicare, they won't have access to the drug in this regard. And although the lab can say there is some problems to provide treatment, it's just like for 1 year. So patients that are not insured, that do not have insurance, they do not really have a good access, even as far as I got in the US for this treatment. And I would say that the utilization of orphan drug regulation to escalate prices and also obtain this 7 to 10 years market exclusivity likely will pose significant challenges to incorporate CDCA for treatment of CTX in SUS. SUS is the public health system of Brazil, and likely to many others low to middle income countries. So if you're gonna pick an old drug and sell it with really high prices, this might pose really challenges to these countries to provide that to patients. So the price perhaps is a barrier that we should think about on how to solve it, at least for these countries. I'm going to talk a bit about how is the process of providing treatments in Brazil. So in Brazil, we have a right, health is considered a right to all citizens. So we have this public health system that should cover health to everybody in the country. Around 75% of the population of Brazil relies only in SUS, and this 25% also have some private insurance. In Brazil, we have Anvisa. Anvisa is like the FDA or like the EMA. So this is the health authority to approve a given treatment in the country. And by now, no treatment for CTX has Anvisa approval. So although it's FDA approved right now for CTX, but in Brazil, we don't have an Anvisa approved. And after Anvisa approval, this just means that we can prescribe this treatment in the country, but it does not mean that this treatment should be given to patients inside the public health system. So we also have an agency called CONITEC. CONITEC is so the Brazilian health system. I don't know how many of you are aware on the NHS, so the process of the health system in England. So the SUS is quite similar to NHS, but in a huge country. So Brazil is it's likely the largest public health system in the world, the SUS. And to incorporate a novel technology or a given technology in this public health system, we should have CONITEC approval. And CONITEC approval is quite similar to the NICE approval in the UK. So we need to have a cost effectiveness evaluation to say that this drug, it's not only safe, but it's also cost effective to be provided in the system. So if the drug is quite expensive, and if we don't have really good clinical data on its effectiveness, so just using biomarkers might convince some regulatory agencies. But when you think about cost effectiveness, it's also necessary to have some clinical benefit and really measure this clinical benefit in quality of life adjusted years to see how many good years I have provided when given this specific treatment. So we don't have Anvisa approval for CTX treatments in Brazil. And as there is no Anvisa approval, we didn't go to the next step. So we also don't have any drug incorporated in the health system. As I mentioned, we consider in Brazil that health is a constitutional right. So everyone should have access to it. And it's a duty of the state. So this information in our constitution provides a gap, I would say, for suing the state. So when you don't have a given drug approved, you can still say, this was not evaluated before, so I could say that this is orphan drug, orphan disease, and I should receive that. And then I can sue the state. And these patients, the 6 patients that were undergoing treatment before the Restore trial in the country that they are using for more than 1 year, these patients sued the state, and some judge said, yes, these patients should receive this drug, although there is no Anvisa approval. And this was the way these patients were receiving the treatment. But as you can see, this is like a quarter of patients, so many of them were not able to access the medication by suing the state. And this has a lot of consequences because when you sue the state should provide a drug, irrespective of the planning of the budget for health, for the whole budget of health in the country, and they pay the full price of the medication. So there is no negotiation about saying, oh, we're going to buy for, I don't know, 100 patients and the price should be lower. No, they pay the full price. And this is really a problem for all countries, but mainly for low to middle income countries. But we have, so these patients received the drug by suing the state. But now we have on 2024, the end of 2024, a different interpretation from the Brazilian Supreme Court, because we had a lot of processes to provide treatment for patients with Duchenne muscular dystrophy for gene therapy for LVDs. And this happened before Elevidys has approval in Anvisa. Now Elevidys has approval in Anvisa, but at that time point it didn't have. And then there was this extraordinary appeal telling that we can no longer prescribe any medication that do not have Anvisa registration. So right now, the scenario would be that because of this pressure to provide expensive treatment, so for Duchenne, for instance, they changed the rule. And right now, even having the RESTORE trial and so on and FDA approval, we don't have Anvisa approval, and we don't have any access anymore, I would say, to CTX treatments in Brazil. For new cases, like the old cases, all the judicial path, it's not retroactive. So if you already sue the state and win, they won't take your rights to receive the treatment. But for novel cases, this is a problem. Today, I received a contact from a colleague from São Paulo, the largest state in the country, saying, "Oh, I just diagnosed children with CTX," and he was asking me, "How can I provide access to treatment to this patient?" And then you participated in the trial. Can you help me with that? And I have to say to him, I don't know. Right now, we don't have a clear path to provide access to treatment. I would still try, even with these changes, I would still try to prescribe and see if by legal ways the patient can obtain the medication. And I also told him, now perhaps you should also contact the labs, the pharmaceutical companies that provide, and see if they somehow could help to provide treatment for this patient. Well, so as I mentioned, we don't have access right now. And so my main points here is that we need to register these drugs with regulatory agencies across countries. So it's not only FDA, it's not only EMA, but different countries also have different regulatory agencies. As in Brazil, we have Anvisa, and perhaps using RESTORE data to help us with that. However, the issue of price, even having the registry, the issue of price is significant. And the argument of so a lot of new drugs for orphan diseases or for rare diseases say, oh, the price to develop the drug is really high, so this justify applying high costs. Here is not the case, because this drug was described in the 1970s. We don't have patent, so we are just, I would say that misusing the incentive mechanisms intended for development of technology for rare diseases likely will lead to difficulties in assessing these drugs, especially to poorer countries like low to middle income countries, as is the case of Brazil. And Brazil is not the poorest country. So Brazil is also a middle income country. For patients that are poorer than Brazil, this issue will be quite harder. And I think that we need a greater engagement from governments and universities to help to tackle these challenges. So I'm aware that in Netherlands, the university decided so they wouldn't prescribe the treatment, but the university would provide the treatment to patients by importing the medications from other regions of the world. But also we should try to talk to smaller pharmaceutical companies or even governmental facilities. So in Brazil, we have, for instance, Fiocruz that produces some medications, and we could talk to the government to say, oh, perhaps this is strategic to the country, this is an old drug, and perhaps the government should take care of that and try to produce this medication in a cheaper way so we can have wider access to this kind of medications. And of course, there is this market exclusivity for the patient, for the states, the countries where the drug was recently registered for CTX. But there is no patent, and there is likely other mechanisms that could help us to provide generic drugs, biosimilars, to at some point provide lower costs. So my message here is that we saw in Brazil that there is a huge odyssey, like a diagnostic odyssey for these patients, and we have a really delayed diagnosis. So the delay was around 16 to 17 years after the first symptoms of CTX. Most patients were over 24 years. There is some studies showing that patients over than 24 years have not so good effect of this medication if they have a good effect. So the patients still deteriorate when you treat they late. So the thing is that we are expecting to have like a really expensive drug by suing the state and provide the treatment to patients where the results won't be that good. So I think there is an urgent need for early diagnosis to ensure access to treatment within an appropriate therapeutic window. So we have a therapeutic window here and should have early diagnosis. Otherwise, we're going to spend really high costs with this treatment when the benefit will be really, really modest. And I think we need to build a healthier environment of mutual cooperation between all the players, patients, specialists, industry, governments, to help to provide treatment to these rare diseases, but in a way that does not compromise the sustainability of healthcare systems. So these are just so we have really expensive drugs that were recently developed, so gene therapy, for instance. And if you pick the 15 products related to gene therapy that are approved in the FDA, EMA, or even in Brazil, just these drugs would compromise around 5% of the whole budget of health in Brazil. And this is really a high amount of money. And if you're gonna also charge on old medication, I think in some point, so this like spending resources on old off-patent technologies, this might only reinforce the failure of treatment models for rare and ultra-rare diseases. So if everyone was gonna say all treatments should be really expensive, old ones and really novel technologies, at some point someone will say we won't pay for that. And I think we should think on how we should tackle these challenges. This is some ideas. I think this is a really hard talk to give. But I was reflecting during the trial, during treating my patients, and it's really bad you don't have a treatment. But it can be even worse when you have a treatment and you don't have access to that treatment. And in our scenario is that we don't have access, and when we have access, we have access in a late stage that patients will not have really the biggest benefit of this medication. I'm sorry to don't provide a really optimistic talk in this regard. I'm quite worried about all these issues. Thank a lot on our research group in neuromuscular genetics, and also mainly the guys that took part on the CTX cohort study, and mainly Paulo that is still doing quite nice work on clinical characterization of CTX. So thanks again for inviting me to give this, I would say, hard talk and polemic as well. But I'll be also happy to answer to some of your questions later on. Thanks.
Thank you. Thank you very much. Okay, so we are a little bit behind time, but I think this is really important to provide an environment for you to ask questions of these physicians and researchers who have just presented. We also have access to those who are online as well. They can hear everything. When you are asking your question, though, please use the microphone so that the people online can hear us. Okay, we have a question right here.
Yeah, I have a question for the last speaker, Dr. Saute. What is the situation in Brazil with regard to cholic acid therapy, Cholbam? You know, because as you probably know, it is effective on CTX, and I would, go as far as to say if you had done the RESTORE study with colic instead of Kino, or in addition to Kino, you would have seen comparable effects on the primary endpoints of the study. And we know that because that's how it was approved for all of the bile acid synthesis defects. So I'm just curious to know, what's the situation of cholic acid therapy in Brazil?
I think Paulo can also answer about that, but we just have a picture on this cohort of patients with CTX, these 38 patients, and none of them were receiving cholic acid. So the patients were taking either CDCA, and some of them were receiving like CDCA and statins. This was the scenario in the country. And I would say that Of course, it would be nice to test in a trial to see similar outcomes as the RESTORE trial. But at least regarding my talk to provide access, at this point, we don't have any of those treatments like cholic acid or CDCA approved in Anvisa. So as far as I am aware, even for other like bile acid defects, like cholic acid is not registered in Anvisa. And at this time point, we cannot prescribe drugs that are not registered in Anvisa because of this movement that happened because of Duchenne, that people were prescribing drugs that were approved in other countries, and the government said, no, not anymore. These drugs are too expensive, and this reflected now to CTX. So at this moment, I would say we can try to prescribe, but even prescribing any of those, cholic acid or CDCA, we might have troubles with the Supreme Court because they said we cannot do it and we cannot argue against them by doing that. So I'm like the most of those patients that were treated previously in that trial were from my center, and I received some questioning saying, oh, how come can you prescribe a drug that the regulatory authority didn't allow you to do it? So I have to also inform myself to see, oh, there is other drugs for other kind of conditions that this happened previously. But right now, the Supreme Court saying that I cannot prescribe anymore. And so it's a really, we should try to, I don't know, if cholic acid, like if you guys are interested in doing that, we can try to talk to the government, talk to some pharmaceutical companies in the country, to Fiocruz, to see if we can produce these drugs in the country at a cheaper cost. And then I think this will allow us to really provide broader access to any of these treatments.
Okay, thanks very much, Jonas. Any other questions? Well, can I have a question? I'll go next then, Ken, then we'll come back to you. So I have a question, and thanks very much to our remote speakers for those very thoughtful presentations. I have a question for Dr. Nobrega. So just to clarify, you presented a really nice overview of kind of the neurological natural history of CTX. So for your study then, presumably most of the patients were not on treatment, with that presentation, and that is reflective of the natural course of the disease without treatment. Is that correct?
Yes, that's correct. And Jonas also was the main researcher in that paper. Most patients were not treated with CDCA at the moment of the study.
Well, hopefully, you'll be able to follow up with Anvisa and try and get the approvals. Hopefully there's a path to that.
Yeah, thank you.
Okay. Dr. Ken Setchell has another question. We'll come over here.
I hesitate to throw this out, but, there is a cheap alternative to colic and kino, and that is to use ox bile supplements. And, we actually presented at Digestive Disease Week last year. You have to be cautious about where you buy them because many of them don't have what they say they have and don't have the concentrations. But, it is a way of, the target of both therapies is to downregulate CYP7A1. You're not targeting CYP27A1. CYP7A1, because you're trying to do that through FXR and downregulate bile acid synthesis, and that can be done with those supplements. The problem is they're not at all regulated, and you just don't know what you get when you buy them. So, but we have used that and of course we use those supplements now in the patients with amidation defects, where they fail to conjugate their bile acids, because it's no good using kino or cholate because they produce tons of cholate. So.
All right, well, let's go ahead and get started. My name is Robert Steiner, and I'll be talking to you first about the importance of secondary findings and CTX nomination by the CTX Alliance. I want to thank the organizers for inviting me today. I guess I think I am one of the organizers, so maybe I'm thanking myself, but in any case, let's go ahead. I do have some disclosures. Most relevant for today, I have been and still am a consultant for Mirum. Okay, so I think a lot of you in this room probably don't know what the ACMG secondary findings list is, so I'll be explaining that. Also, how are gene disease pairs added to the ACMG secondary findings list? And first of all, what is ACMG? That's the American College of Medical Genetics and Genomics, the professional organization for clinical and laboratory geneticists. So the overall framing question is, what should genetic and genomic testing labs do when they're doing genomic sequencing for diagnosis when they come across by accident or incidentally findings that may be diagnostic of a treatable condition, but one that's totally unrelated to the initial reason for the genetic or genomic testing? This is sometimes called unanticipated, incidental, secondary, or additional findings. So the naming of this gets a little bit complicated. We're going to call it secondary findings today. I think I do have some definitions after this. So hopefully the question makes sense here. In other words, if you send a test, let's say you think a patient has cystic fibrosis, you want to send a genetic test, but you're not sure they have cystic fibrosis, they may have something similar. So you send a test that's kind of a broad genetic test to a laboratory. And they do like a whole exome sequence, and they find CTX. Should they report the CTX even though that's not what the doctor asked for or not? That's kind of the question. Yeah. Well, not everybody would necessarily say that, but I think everyone in this room probably would. Yeah. Thank you. So we're talking today about findings on genomic testing. And there can be primary findings, incidental findings, or secondary findings. So by definition, primary findings are the results that are sought related to the reason for testing. So in other words, related to the patient's signs and symptoms, their phenotype, what they are expressing. Incidental findings are results that are discovered unintentionally or even though they were not being sought. But then a kind of a different subset of that are secondary findings, results that are sought, intentionally sought, but not related to the reason for testing. So we think they're important enough that even if the doctor or the healthcare provider isn't looking for them, we think they should be reported. So originally, ACMG made some recommendations with the goal to identify and manage risks for selected highly penetrant genetic disorders through established interventions aimed at preventing or significantly reducing morbidity and mortality. And they conducted a year-long consensus process and review by outside experts to develop a minimum gene list to be evaluated as part of genomic sequencing. So in other words, the goal was to develop a list of these genes, essentially disorders, that we think we should give the results to people even though they weren't looking for those particular results. And this original recommendations led to a 56 gene disease pairs recommended for a secondary findings list. In other words, disease-causing variants in the 56 genes should be reported regardless of why sequencing was ordered, regardless of the patient's age, and to all patients undergoing clinical genomics sequencing, either exome sequencing, genome sequencing, or other very broad, comprehensive genetic or genomic sequencing. And patients, there should be, initially there was a thought that we shouldn't even allow people to opt out of that. It should just be done. Now, thankfully, someone else, I think it was Andrea, talked to you about variants of uncertain significance, or VUSs. That is the bane of the existence of laboratory and clinical geneticists. That's a big problem in our field. We find changes in the genetic or genomic sequence, and we don't know if they cause disease or not. In this case, for secondary findings, we're only going to be reporting pathogenic or likely pathogenic variants, not these variants that we don't understand, because that complicates things even further. So we're talking here about opportunistic genomic sequencing. And this is a bioethics commission classification of types of results of medical tests We're only going to focus on the bottom one, secondary findings. So the practitioner aims to discover A, let's say gene or disease A, and also actively seeks D, gene or disease D, by expert recommendation. And the experts here are ACMG and their panels and their discussion groups. And so the American College of Medical Genetics recommends that laboratories conducting large-scale genetic sequencing for any purpose should actively look for variants underlying 24, or in this case 56 now, and you'll see the number's going to go up, phenotypic traits. So this dates back to around 2013 when Robert Green at Harvard and others published the original ACMG policy statement on listing 56 genes for which, when sequencing is done, this group felt that the results should generally be given back to the patients. In 2014, a work group was constituted to review these secondary findings and also to think about starting to update this list as, let's say, new treatments come along. And during this, around 2014, 2015, I think a lot of us in the field convinced the experts that there really should be an option to opt out. So some patients, families, may not want the secondary findings results for various reasons, and we can talk about those at the end if there are questions. But in general, I think the feeling is now you should be allowed to opt out of that secondary findings information. By 2015, the work group and gene nomination process was announced at an ACMG meeting. And so the gene nomination process is really what's the important part for all of you here. Initially, it was just this professional organization, ACMG, that was making all the decisions for all of you. But now, professionals and lay people can actually nominate genes for this working group to consider for addition to the secondary findings list. And by 2017, the policy statement was updated with a list of now 59 genes. Some people refer to these as the ACMG secondary findings list, and that was SF version 2.0. So I give Robert Green a lot of credit for kind of being one of the leaders of this field and getting us at least starting to think about these issues. And he was the first author on the bottom paper with the ACMG recommendations for reporting of incidental findings in clinical exome and genome sequencing, with a lot of other luminaries in the field, including Les Biesecker. So ACMG surveyed their members in 2015, and more than 80% of respondents supported an option for patients undergoing genomic sequencing to decline secondary findings. This is the opt-out that I was talking about earlier. The survey results were published not long thereafter. So by 2017, I told you there was an update. This was based on a new multidisciplinary working group. They developed a process for nominating these genes and conditions to be added to the list. And also at that time, ACMG adopted a semi-quantitative framework for assessing the actionability of genes, looking at things like the severity of the disease, how serious is it, the likelihood of the disease showing signs or symptoms. So sometimes people can have a variant in a gene that causes disease A, but just having the variant doesn't always lead to signs and symptoms. That is called penetrance. They also consider how effective treatments are. And what is the overall strength of the current knowledge base about the gene or condition? How much do we actually understand about it? So in July of 2015, a fifth criterion was added: acceptability of the proposed intervention based on the risks and benefits. In other words, it's not just whether there's a treatment or intervention, but is that really, what is the risk benefit of that intervention? There are some interventions that maybe, let's say, a very difficult surgery could be the treatment for a condition with lots of risks, all the way to taking a pill once a day and you're essentially cured, and everything in between. So the nomination process was developed, and the thought was that nominated genes should have an established gene-disease relationship. So we should understand, we should be very clear that the defects in this gene actually do cause the disease in question. That sounds like it's straightforward. Turns out it's not all that straightforward. And there's a group called ClinGen, which is a national group, originally NIH funded, that has curation expert panels that evaluate these gene-disease relationships. And also, the nominated genes, the conditions should be medically actionable. There should be treatments or some other intervention available. What is the process for nominating conditions or genes? Consider additional factors such as the likelihood of early clinical diagnosis by a physician. So there's no need to report these secondary findings if these are conditions that are blatantly obvious to any clinician. If a patient has this particular sign or symptom, they're always going to be diagnosed, then we don't need the secondary findings. And then it's important to consider what are the molecular genetic characteristics? What is the inheritance pattern? What type of variants are observed and so forth? Another challenge is what is the interpretation burden on the labs for these secondary findings? How much extra work is it for them to look at these other genes, look at the variants in those genes, report the results of those other genes and so forth? If this was a huge burden on the labs, then it would be problematic. And finally, consider the availability of a confirmatory diagnostic test. If we're just reporting variants in genes and there's no other biochemical or clinical test to confirm the diagnosis, that would be problematic as well. So all of these features are considered in the nomination process for nominating genes and conditions for consideration for addition to the secondary findings list. Is this making sense so far? Okay, good. I've been doing this for so long. It's second nature for me, but I'm trying to explain this to people who probably haven't heard of this before. So in 2017, the update added 4 genes, removed 1, and rejected 1 gene that was nominated from inclusion. This was known as version 2.0 of the secondary findings list, and people referred for a long time to the ACMG 59. That's going away because now the list is larger than 59. How often are secondary findings found? Does this really occur? Is this just something that happens very rarely? Well, it turns out we have data on this now, and it's somewhere between 2 and 3% of the time. In other words, when we do comprehensive genomic testing, between 2 and 3% of the time we find one of these secondary findings, gene variant combinations, that we think should be reported back. So now, fast forward to 2021, and it's been decided that the gene list will be updated on an annual basis. The group also, the work group for secondary findings, reaffirmed the choice to opt out of reporting for secondary findings in all settings. So universal ability for patients and their doctors, healthcare providers, to say we don't want the secondary findings results. So this was published then. The ACMG secondary findings 3.2 list, a policy statement of ACMG. And my colleague David Miller is the lead author there. So how does one nominate a condition for secondary findings? And I think you're starting to get the idea of what might be happening here. But there's an online form, and you can submit the forms to this email address. And so a group of us, Gene Pickford was the lead nominator, Andrea and I and others helped, and lo and behold, we nominated the CTX gene for addition to secondary findings. And that gene is CYP27A1. So the good news is we nominated the gene. The bad news is that was almost 3 years ago now, but that's not the end of the story. You can see here the part of the nomination form. It wasn't too difficult to fill out, but nevertheless it did require some work and some back and forth and 3 years of consideration. But we were successful. Yay! So I have up here manuscript draft. That's because I made these slides before there was before something happened that I'll tell you about in a minute. The ACMG SF version 3.3 list for reporting of secondary findings in clinical exome and genome sequencing, a policy statement of ACMG, was submitted to a journal called Genetics in Medicine, right? And so who's the editor of that journal? I am. And so who's giving a talk today, and wanted to make sure that I wasn't just telling you about a manuscript draft, because that wouldn't be a good idea for me to give out details of a paper that hadn't been actually published. So this paper was published Monday of this week. And 3 new genes were added, ABCD1, CYP27A1, and PLN. And there is the actual publication. I kid you not, it was on Monday. Well, here's what happened actually. So on Monday, I'm thinking I got to give my talk on Friday. This has to be published. I'm sure it's published by now. I haven't seen it yet though, which is kind of odd. So I emailed my director of publication. I said, "What's up?" She said, "Oh, we're told it's published today, but let me look." And when I looked, it wasn't. But we have 2 websites for the journal. And on one of the websites, not the one I looked at, it was there. And ultimately now it's on the second website, a little hard to find. But in any case, it was published. It is published. And you can see there's a recommendation for addition to the list of CYP27A1. So what are the implications of this? What does this mean? This is good news, but why is it good news? Well, now every time a patient has genetic or genomic sequencing for whatever reason, if it's comprehensive, like exome sequencing or genome sequencing, when that sequence is analyzed and there's a variant in CYP27A1, that will be reported. So people will find out that they have CTX even though they're being tested for something else. And we've already heard about delayed diagnosis from both Bart and Andrea and our friends from Brazil even, that there's a huge delay in diagnosis of CTX. So we're going to find more patients with CTX because of this secondary findings. More people with CTX will be identified, some even before they have symptoms. And that's just not theoretical, that is happening. So thank you to David Miller, who I said was one of the co-chairs of the work group for secondary findings and provided a bunch of slides. Jean Pickford and I, who worked together on this, Andrea helped, Trevere helped, Amy Ponte, when she was with Trevere, was a big help, and Rana Dutta from Miram. Thank you all. So I think we're going to hold questions for afterwards. I'll take a breath and go to my next, I think that's my last slide, yeah. So go to my next slide set.
While that's coming up, can I ask a quick question?
Yep.
So, and from a clinical standpoint, if somebody has a CAT scan of their chest to evaluate shortness of breath and a tumor in the liver is seen, it would be absurd not to report that?
Yep.
Oh, I'm sorry. So it would be absurd not to report that. And obviously genetic data are a little different, but do you want to comment on this? Because you heard at the beginning, of course I want to know.
Yeah.
And so
yeah, it's a great question.
To actually exclude things or even make it such a complicated process is weird.
Yeah, you're absolutely right. And so a couple things. Remember, this is starting to evolve in about 2013. This was the brave new world of genetic and genomic testing. This was new technology. People were a little bit uncomfortable with it. But Robert Green and some other colleagues and Jim Evans made exactly the point you're making. Radiologists do this all the time. It works. We don't hear a lot of problems with it. And so that was one of their arguments. And I think in the end, I think 5 years from now, it is going to seem absurd that we even had this question. Okay, we're ready to go. So switching gears, the topic of this talk is building a CTX patient registry, a path to valuable research data. So I think a lot of you in the room are probably familiar, at least in basic terms, on what a patient registry is, but some of you may not be. So a patient registry is a secure database that collects and stores medical and health information about people with a specific condition. In this case, we're talking about CTX. the data system that stores that information has to comply with privacy and security standards and protect individuals' PHI, protected health information. It can include both clinical data, let's say from healthcare providers, or patient-reported information, or both. Registries are essential for understanding rare diseases and improving diagnosis, treatment, and care. So they're actually ways of gathering a lot of information about a lot of patients in one place, and that helps us clinicians and researchers learn more about the condition, because none of us alone sees enough patients to understand the condition fully. So why do we need a patient registry? I'm arguing that we need a patient registry for CTX, but I want to convince you that we really do need that. So what are some of the challenges in CTX that we hope to overcome by having better disease registries? Well, there's large clinical, There's large clinical heterogeneity also within families. So even two siblings, and some of you families know this, two siblings can both have CTX, they have the same genetics, well, at least in terms of the CYP27A1 gene, they have the same variants, and yet they express the condition differently. So do we know the complete... Should I just tell you when to advance? Yeah, so we need to go back one. Okay. So do we know the complete disease spectrum and the distribution of phenotypes? What are all the potential signs and symptoms? Do we know the genotype-phenotype correlations? In other words, can we predict what signs, symptoms, and complications someone is going to have based on either their biochemistry or their clinical genetics laboratory genetics findings, their genotype? And there are specific challenges related to CTX newborn screening. We mentioned this earlier in some of the talks, that there's ongoing efforts to develop newborn screening for CTX. A registry would be very helpful because we've been asked to provide a case definition. In other words, what defines CTX exactly? Which patients do we want to detect by newborn screening? When do we start treatment? And what are the criteria for starting treatment? Next slide. So why it matters? Well, CTX is a rare disorder, and so collecting data from around the world is essential. We don't have enough patients in any one country to learn the full disease spectrum and response to treatment. A registry would help us identify patterns in symptoms, disease progression, and treatment response. It would support clinical trial readiness and development of new therapies. So in other words, if we knew really accurately what percentage of patients develop what particular clinical findings, that would be very supportive of developing additional clinical trials, testing new therapies. It enables better long-term care planning and guidelines for physicians. So we know that when do these signs and symptoms typically progress in CTX. And then finally, it establishes and refines criteria for CTX newborn screening implementation. Next slide. And what can a registry tell us? Well, it further defines the disease spectrum. It shows different symptoms, progression, and why and how some people respond differently to treatment. So not everyone with CTX responds the same way to CDCA. It can also help us try to find out if certain genetic changes or variants in CTX are linked to specific symptoms or lab results. And then I think it's really important to compare outcome data from different countries. These countries have different CTX populations. They have a different genetic background. They have different newborn screening. They're going to have different newborn screening implementation strategies. And there are different treatment strategies. So you heard about availability or lack of availability of the medications. That affects the patients, and we need to capture that in registries. So by collecting information from patients around the world, we can figure out the best ways to diagnose, treat, and monitor CTX and make sure everyone is using the optimal approach. Next slide. Okay, so now kind of the nitty-gritty, governance. Who owns the registry? Who hosts it? How is it funded? So it's my strong opinion that patient registries should be independent. They shouldn't be owned by pharmaceutical companies or contract research organizations. They really should be independent. My bias is that they should be hosted by patient advocacy groups, and that's often the case. So in this case, I would suggest that the CTX-A, in collaboration with other country patient advocacy groups, should host a registry. And there's not really, I don't think there's really ownership of the registry. It's more, who are the custodians of the registry? The patients really own the registry, their data. They own their own data. The patient advocacy groups are just housing that data, protecting it, and being good stewards of the data. There should typically be a steering committee to oversee how the data is inputted, how it's used, how publications occur. So actually, I list some of those features here. Registry participation would be guided by the steering committee. Privacy and security issues dealt with. Data storage can be a challenge. Requests for data analysis. So who decides whether someone who asks for the data should be provided with that data, and what protections should be in place? That would be the role of the steering committee as well. And finally, publications. The steering committee or a publications committee, being a subset of the steering committee, can decide who can develop manuscripts based on the data. Next slide. And then funding. I would say registries don't have to be very expensive, but there are costs involved, and the costs are not trivial. I think it's important to maintain independence of the registry despite potential industry funding. So there shouldn't be a problem with accepting funding from pharmaceutical companies or other industries, laboratories, and so forth. But the funding should allow the registry to remain independent. So for example, I think, let's say a patient advocacy group owns a registry. They can receive funding for that registry by a pharmaceutical company, but that should come by way of an unrestricted grant with no strings attached and no ability to control the registry. Research grants can sometimes help support registries. That's challenging, especially in the US these days, but nevertheless, it's possible, and more possible, I think, now in other countries. One way of protecting the independence is by funding through a blind trust that's governed by the patient advocacy group. And then it's always going to be the case that donations and potentially endowment funds are needed to support these registries. And you all may have other suggestions in our question and comment period. I think I'm almost at the end. Next slide. Structure, though. There are important considerations for developing a registry that's actually going to be useful, potentially able to talk to or interact with other patient registries. And that becomes more possible when, whoops, I guess I'm not almost done. Go back one more, getting ahead of myself here, more ways than one. So we use HPO terms for phenotype descriptions. HGVS is variant nomenclature. We should use standard nomenclature and standard structure whenever possible. Second bullet point, we should include patient-reported outcome measures, not just healthcare provider measures. Bianca Stelton and a group of us published this paper, and that can be a good guidance on what kinds of things to include in a CTX registry. And then data capture should be using a format that's widely available and not likely to go away. Next slide. Let's skip that one. I think I went over most of that. So what kinds of things can be captured in a registry? I'm sorry this is small and I didn't mean for you to be able to read it, but it's clinical phenotypes. All of the, you heard all the signs and symptoms of CTX earlier, and we would want to capture a lot of those clinical phenotypes. Next slide. So those were symptoms. We want the signs, which are things that are obvious to healthcare providers, maybe not to patients. Next slide. Biochemical phenotype. We want the laboratory parameters to be able to be captured. Next slide. Neuroimaging. Next slide. and additional medical investigations. You heard about osteoporosis, for example, so bone density test results, EEGs, neuropsychologic testing, and so forth. Next slide. And patient-reported outcome measures, I'm not going to go over these, but things like that are important to all of you, to patients. Issues about gait, vision, ability to walk. Is your speech understood all the time? Next slide. Who can enter the information? Well, different registries are different. Some registries have patients literally going to their laptops or their home computers and entering their own information. Sometimes physicians in their offices enter information. My bias is that we should allow both in a CTX registry, patient information as well as healthcare provider information. Next slide. So the goal is to develop, the ultimate goal for CTX is to develop a global inclusive registry. We're going to be talking more about this. We started talking about this mainly at the Israel meeting 2 years ago, and we'll be talking about this again at the ICIEM meeting. There's a satellite meeting on CTX, September 1st, 2025 in Kyoto, so I hope you can all come. The main session will focus on establishing a framework and identifying optimal outcome measures, and the CTX Alliance will lead and facilitate development of standardized registry questions and templates, collaborations with clinicians, researchers, and patients, and ongoing updates and training to ensure effective data entry and use. Next slide. So we will try to keep you all informed as our plans progress, hopefully for development of a CTX global registry. Patient community and international patient groups are the key to a registry's success, and together we're building a foundation for better care, research, and future treatments for CTX. And I'll just say one more thing. So it would be tremendously difficult, I think, to develop a global registry that everyone throughout the world can use directly. But there are ways for individual countries to develop their own registry, but for the registries from each country to be able to speak to each other and interact with each other almost seamlessly. So I think that's the goal that we're looking at. So I'll stop there. Thank you.
Being a prospective rather than, in other words, you would enroll. Sorry. Let me rephrase it then. Would you see the registry being activated in a prospective manner? So you only now, if you start today, you only register those new patients that you, rather than trying to go and add in existing patients for which some of the data you may not be able to get because historically it's too many years ago when perhaps they were first diagnosed?
Yeah, it's an important question, and I think we haven't decided on the answer to that question. I think certainly if we're collecting information from, let's say, electronic health records, it's not a big problem to go back retroactively. This is objective information. It's in the electronic health record. So my bias is, at least for the healthcare provider part, I think we could go back and enter retrospective data. The patient-reported outcome measures, that's a lot harder because you're asking patients to remember how they felt 5 years ago and so forth. But that's that's one of the questions we'll have to deal with.
Okay, any other questions? All right, so our next presenter is Abbey Cook. Abbey will be presenting on the patient perspective of a patient registry.
Thank you so much for this opportunity to speak to you, and I'm so glad to have met pretty much everyone in this room by this point, but I'm really honored to be up here and talk to you. My name is Abbey Cook, and I have 2 children. You'll see them soon when we get our first slide, who have CTX. They are now 35 and 33, so, but they were diagnosed less than 3 years ago. You could have the first slide. Yeah. Okay. So meet Ben on the left and Zach. Ben is 11 there, and Zach is 9. So they looked perfectly healthy, except they had a lot of problems in school. They had behavioral problems, and every year their symptoms were increasing. We got new diagnoses. Oh, they have a convergence insufficiency. He's having trouble learning to read. Eventually it got to the point for at least one of our sons that he developed really severe psychological upset. And that led us on a chase to find out, what we could do to help him in that. But I just wanted to say that I think it's been said before, but one of the key features of CTX is how long the diagnostic odyssey is. And may I have the next slide, please? And I can tell you, we are here now. This is probably less complicated than the diagnostic odyssey that we are on. And I think many who are sitting here and many people at home can completely identify with this. So once again, our diagnosis was at 30 and 32 for Ben and Zach. So, okay. How did we get to this diagnosis? In his late 20s, Zach started to develop a thickening on the backs of his ankles. We didn't know what they were. It took 3 podiatrists over several years to finally find out that those were called xanthomas. But even then, we didn't get to the CTX diagnosis. Finally, though, we were able to research what xanthomas were, and found that there's just few conditions that cause them. And so at last we got to a CTX diagnosis, and our sons are incredibly fortunate to be at Mass General Hospital under the care of Dr. Amanda Nagy, who we're lucky to be sitting in the audience here. So we didn't realize they had all these disparate symptoms, and we had no idea there was something underlying all of them that was treatable. And this is one of the most outrageous things about CTX is here's this condition, it's treatable, but it's so serious, and it's detectable. And I'll tell you a little story. Our kids were born in California, and California keeps its blood spots. So when we found out they had CTX, we requested the blood spots be sent to Dr. DeBarber. And 30 and 32 years later, on these ancient blood spot cards, she found the biomarkers for CTX. That's how excellent the testing is now for newborn screening, that a 30 and 32-year-old blood spots could be identified with CTX. So I'm really getting off script here, but there's so much to say. Like many CTX families, our experience included learning disabilities, autism spectrum disorder, physical deterioration, and psychiatric symptoms. So 3 years ago, Zach was so ill, he began to talk about taking his life. The heartbreak of CTX is this, and I referred to this, and we all have heard about CDCA and cholic acid. There is a pill taken 3 times daily that prevents and in some cases can reverse the damage, but many people don't know they have CTX until the damage has occurred. It's too late. I wish for every one of the leukodystrophies at this conference that there could be a pill like there is for CTX. Unfortunately, there's not. And I also wish that we can get to an earlier diagnosis. And this is where, as Bob so eloquently said, the registry can come in to be helpful. And we can go to the next slide, please. So there are a lot of heroes in the CTX story, and here are just some of them, and we have more heroes in the room here. But over 40 years ago, researchers and physicians, and I want to underscore patients also, discovered the medicine to treat CTX. I'm grateful every day to every single one of these people because they've saved my son's lives. The data, careful and sustained observation of the patients and the researcher insights made this discovery possible. We're so fortunate to have this knowledge and this medicine for CTX, but there are still so many questions, so many problems for CTX patients that must be addressed, and we've heard about several of them, many of them, most of them. Scientists and clinicians continue to observe and record the symptoms, treatments, and challenges of their patients. But at this point, the rarity and the variability of symptoms and their onset continue to perplex and to slow the identification of the illness. For example, my sons have identical variations, but their symptoms vary very much. And that is where the importance of the registry is, answering questions like that. But right now, there's no organized system for gathering the findings of the researchers around the world who are working on CTX. We need this system, as Bob mentioned, because of the rarity. It requires as many patient experiences to be collected as possible to gain the most accurate and useful portrayal of the disease. The data for the global community of CTX scientists and researchers must be findable, accessible, reusable, and compatible. And that is where the registry comes in. And we can go to the next slide. So Bob did all of this, so I won't go over that. I will just say that when we hear the word registry, if we're just patients and families and not medical professionals, we might think of a curated selection of gifts for a couple that's about to be wed. But in a rare disease registry, we will anticipate a different kind of gift. As families with rare diseases, we can enroll in our registry, should we be so lucky as to have one. And we can make a contribution in that way. It's a gift. It's a record of our experience with the disease. So who's the recipient of this gift? We are the entire community, because the gift comes back to us in the form of knowledge that can be used to hasten diagnosis, improve treatment, and perhaps eventually cure our rare disease. So since this has been talked about and so nicely before, I won't go into it, but we're back to seeing Zach before treatment and after treatment. But I just want to say, over the years, my husband and I tried everything we could to help our sons. But that's the story you have lived or witnessed. If someone told us that there was something that would be helpful, we did it. Shortly before the diagnosis, though, when we had exhausted every treatment, seen every doctor and therapist across the country, tried everything, we had reached the end of the line of things we could do. There was nothing more we could do. I think many in this room and attending virtually have experienced this feeling of helplessness. Now I see a most effective way to combat that helplessness and to help my sons and to help others with CTX, joining the coming CTX patient registry. A registry gives us agency to do something very important for our families. The registry will be a crucial tool to centralizing clinical information. It will take time to develop. But when the CTX registry opens, I will be among the very first to enroll our family, and I hope other families here will too. So after hearing some of the speakers, I just also want to say, I hope the registry will help to identify the access problems that we have around the world. I think it's outrageous that we have a diagnosis and people can't access the treatment. I think if I were a parent in a country in that situation, I'd be screaming. But anyway, back to Zach. He's a very good example of CTX. Zach, if we looked at the neurological symptoms, he would check some from column A, all from column B. He had so many neurological symptoms. Since he's been on treatment, it's been a remarkable change for us, and that's why we need to get as many people on treatment as possible. They should not have to suffer. But I wanted to read to you, I hope you don't mind if I take time. Zach is a writer. Ben is an artist, but Zach is a writer, and I brought some of his words here. I think they probably express some of the other feelings that other folks with CTX have. So the first one is a poem, and this is an excerpt from it. Taking it upon myself to hobble from that which one can never flee, trapped in my head, occurrences years past, in my thoughts I see. There is no escaping the chemicals and stress caused by my blessed and cursed brain. Memory for some things good, but mostly bad. Words are much the reason I stay sane. So that's 3 years ago. Now, look at the attitudinal change in this. Zach just finished writing a novel, a 200-page novel, about 3 weeks ago, and he's revising it now. He's created the most marvelous characters, and I'll read an excerpt from that book. Bertha noticed her line of vision and said with a smile, "These herbs represent 4 feelings and emotions, dearie. Parsley represents comfort, sage means strength, rosemary is love, and thyme is courage. And goodness knows we need all of them in these troubled times. Plus, they help to make a fine dinner." He has a sense of humor again. It's incredible. So we can go on to the next slide. We all want to see an earlier diagnosis for people with CTX, earlier than what Ben and Zach have, and many others here. And ideally, this would happen at birth. And with the newborn screening test, that is superb. It has very low false positive, false negatives. We need to get that going, but we need to identify the other people who are walking around with CTX. And again, that's where the science can come into play, and the registry, gathering all that data from as many patients as possible, can come into play. And I want to say thank you also, not only to the scientists and physicians and the patients who made that research possible, but our family has been helped so much by the CTX Alliance and the ULF. We went from being depressed and isolated to now we're optimistic and connected. But there's still so much work to be done. And I'm making the case for all of us to participate in the registry. And I'm passing around a card. We're trying to gauge your interest, hopefully high. But this registry will be one of the most powerful ways that you can help your loved ones. So please feel free to reach out to me. I'll finish passing out the cards, but the folks on the Medical and Scientific Advisory Board, the folks who are working on the registry, they are all ears. They want to hear from patients and families, and they want to bring the community together. So let's do that. Thank you guys so much for listening. Okay.
That was just very heartfelt. Thank you very, very much. I know you opened up your heart to everybody and shared your story, and I really appreciate it. I'm sure we all appreciate it here too. Okay, we have another speaker, Dr. Jennifer Rossen, and she's going to speak to you about her project.
Thank you. Thank you guys for having me. And again, Abbey, it was so nice talking with you at lunch and hearing your story and meeting many of you. It's really an honor to be here and be a part of this group. So I'm a pediatric ophthalmologist. I actually work here in Chicago, so I didn't have to come very far. So that was very nice. But it's really nice to be here. I'm working on some genetics and of pediatric cataracts, which brought me to CTX. So I'm going to give you a little update on some of the work we're doing. There's a lot of people in this room that are involved in this initiative as well. So we can go to the next. And I'm also a consultant for Miram. And this is just a brief outline. So I'm going to go back a little bit, and I apologize if there is some redundancy here, as well as stuff you already know. Next slide. Thanks. Again, sorry. Okay, so I was trying to come up with how to describe genetics. I know we've been talking a lot about it, but for some of the patients in the room who might not be as experienced with this, I started trying to come up with it myself, and then I decided to ask ChatGPT to explain it for me. And they actually did a really nice job in about 2 seconds, and came up with a really nice allegory of genetics. And even made that picture. They're like, do you want a picture of this? And I said, sure, that sounds great. So they came up with this. So I apologize if some of this is redundant or you already know this. But how ChatGPT describes genetics, DNA is a recipe book. So it's a recipe for your body. It tells your body how to grow, look, how to work, and every cell in your body has this recipe book. So every cell has all of the DNA in your body. The chromosomes are the big folders that hold all the pages in the recipe book. You have 46 of these folders, 23 from mom, 23 from dad. The genes are the instructions on each page of your DNA recipe book, and they tell your body how to make something, color of your eyes, how tall you are, and alleles are different versions of the recipe or different versions of the gene. And so they can tell you, okay, let's say there's a gene for eye color. One allele may say make blue eyes, the other may say make brown eyes. And you get one allele from each parent. Next. Okay, so genetic testing basics, what we're looking for are changes from the quote unquote normal or variants like were described before in your DNA. And then although most humans have over 2,000 variants in their DNA, not all cause disease. So next. So why get genetic testing? So we want to try and identify a genetic cause for a patient's symptoms that may require treatment or screening. Can this disease be passed on to other family members? And I put in here a disclaimer as well, just the crucial importance of genetic counseling. There's genetic counselors who really specialize in helping patients pick the right test, understand it before, and how to interpret the results afterwards. Next slide. So different types of tests. We have targeted panels that can check just for specific genes that are associated with your condition. And so here's the Miram sponsored panel for the cataracts, which CYP27A1 is on. You can get tested with a swab, a buccal swab of your cheek by spitting into a little cup from your saliva or blood. And as was described previously, you can give all of your exomes, or basically all the coding parts of the DNA, the ones that make the genes that make the protein, or the whole genome, including all of those other parts of the gene, the DNA that don't necessarily make a protein but can affect how a protein is made. And those are the tests, like was described before. It's very exciting now that CYP27A1 is now part of the secondary findings with these whole exome and whole genome sequencing. And so all patients who get those will now be tested for CYP27A1. Next. So again, we've kind of discussed this before too, but so the results of the test are positive. You have a variant in the gene that's associated with the disease that's likely to cause the disease, inconclusive, like has been discussed before, the VUS. So either the variant itself, we're not sure if that can cause the disease, or it's in a gene that we don't know if that gene is really associated with the disease or not, or negative, that there's no variants in any of the genes that might be associated with your symptoms. And so how do we know which genes are associated with diseases, and how do we know if a variant is likely to cause a disease or not? So that brings us to ClinGen, what Dr. Steiner mentioned, and that's the group that I'm working with to try and work through the cataract genetics, starting with CYP27A1. So we've discussed before that the purpose of this is to try and better understand genetics and gene-disease relationships. Next slide. So this is ClinGen's like beautiful slide of everything they do, but just for general, you can click twice, please. Thank you. So basically, two of the big things are which genes are associated with specific diseases, and then which variants cause disease. So then getting into genetic testing for CTX, which I'll breeze through this because we've talked about this. But CTX is caused by biallelic, so two alleles, one from the mother, one from the father, that are determined to be pathogenic or likely pathogenic, which just means that they are likely to cause the disease in CYP27A1. And so why am I talking about this as a pediatric ophthalmologist? And then next slide, please. Because cataracts are usually the first presenting symptom that we understand, that we see. Because as we know, diarrhea is just very common, loose stools in babies. That's not often identified, but most kids don't get cataracts. And so I think it's really important that as a pediatric ophthalmologist, that we consider this, that we consider a syndromic association with cataracts. There's actually over 200 genes that are associated with syndromes and cataracts, but not most pediatric ophthalmologists offer genetic testing yet for patients. And so I think it's really important and something that I've been really talking a lot about. I try and bring it up at all the conferences I go to and really trying to encourage that awareness for the pediatric ophthalmologist. And then again, the same thing, I think it's good, repetition is how you remember things, but as we've said, diagnosis is late. And so by this point, most patients, by 33, almost 34 years, not all patients, but many patients have had cataracts at that point, and that delay of symptoms is something that we're trying to improve. So as I've said, our hypothesis, with the group that we're working with is that earlier and improved genetic testing can identify patients with CTX sooner before neurologic symptoms develop. So we're trying to encourage more genetic testing for patients with cataracts, as well as improve how we analyze the genetic testing and the genetic testing specifically of CYP27A1. So next slide. Okay, so that was a big wind up to what we're doing, which is the ClinGen efforts for CTX. So next slide. So when we're talking about gene-disease relationship, so another group, the leukodystrophy and leukoencephalopathy GCEP, so the gene curation panel, has already determined that definitively CYP27A1 is associated with CTX. We all knew that, but it had to be put out there so that we can do the rest of the work. So that's been done, which is great. So we know that. So then the next slide. I've worked to create this group, the ClinGen Pediatric Cataract Variant Curation Expert Panel, and I'll explain that a little bit more, but what we're trying to do is better determine how the labs can figure out what variants can cause disease and what variants don't cause disease. Next slide, please. So this is our group. And, we were, again, there's over 300 cataract genes. But you have to start one at a time. And we've decided that CYP27A1 for CTX is where we should begin because of the importance of the necessity of early diagnosis for patients with pediatric cataracts, as well as that there's a treatment. And so that's where we've decided to start. Next slide. Okay, you're not supposed to read that teeny tiny letters and words there. But what this is the American College of Medical Genetics, as Dr. Steiner had discussed before, comes up with a list of criteria. I'm checking myself. Okay, sorry, I only have a couple minutes. But of criteria of how we determine if a change or a variant in the gene is associated with disease or not. So the ones over on this side say, yeah, that variant is too common in the population, probably doesn't cause disease, even though it's in CYP27A1. These on this side say, yeah, it's more likely to cause disease. And those things that we look at are how frequent is the variant in the population? Does that patient who's being tested have biochemical markers or clinical findings that are associated with CTX. And that helps the lab determine how you pick if the variant is causing CTX or not. And right now the rules are great, but they have a lot of inconsistencies in them. So these different ClinGen groups are working to create very specific rule specifications for how to use these rules for each gene. So that's what our group is doing right now, is we're trying to come up with a standardized list of how labs should look at CYP27A1 and decide, is this variant in CYP27A1 causing CTX or not? And the importance there also, like what Dr. Steiner was saying, is that with the secondary findings, they're not reporting variants of uncertain significance or less, only those that are pathogenic and likely pathogenic. So we want to make sure as many patients who truly have CTX as possible are identified by genetic testing. And then you can click, and then this is the same from Dr. DeBarber, which he was saying, right now, 38% of the known variants are uncertain significance. So part of this work is trying to decrease that number. Some of them will become benign. Some of them will become pathogenic and likely pathogenic. But those that were VUSs right now, if that patient was undergoing secondary findings, like for something else, they wouldn't be told that they have that variant. So we really want to make sure that all patients with CTX are identified who get genetic testing. And then, so next slide, I'm pretty much done. So in addition to all the wonderful things, we've talked about with the patient registry, that really also helps our work, because how we define these rules is based on what's in the literature or what's available for patient information associated with different variants. So that helps. It's a little bit of circular logic, but it helps both ways. And so we're very grateful for all the information that many of you have put out into the literature that's making this work possible. We're hoping to complete the work for CYP27A1 in the next 1 to 2 years, so that when labs are looking at that gene, they'll be better able to analyze it. And trying to, my big passion is really trying to help get diagnoses for patients with pediatric cataracts and making sure that other pediatric ophthalmologists are aware. So thank you. And then the last slide is just, we have a big group. You'll see that a lot of the people, Dr. Setchell, Dr. DeBarber, Dr. Pamparo, they're all on our committee with us. And so if you have any questions, please reach out. And thank you guys so much for having me. It's really an honor.
Okay, I'm a talker with my hands, so I'm going to put on the lavalier. Hold on one sec. Nolan and I have become good friends. Okay, hold on. Nope, that's not working either. All right, how's that? Everybody can hear me? Okay, so I'm going to start my slides. First of all, I just want to say, sitting here listening to all of this work and all of these advances that are being done for CTX, it's just incredible. Thank you so much for all the patients, and on behalf of the CTX Alliance, just listening to these projects and this work and this energy and this enthusiasm. It's just amazing, and it's really made a big difference. So I'm going to share a little bit about the CTX Alliance with you. I'm calling it my annual organizational update. So I'm going to talk to you about a couple key projects that our organization is working on. The first is the newborn screening program. We've heard about it today in lots of different talks, but I want to update you as to what's going on at the federal level of newborn screening. So as you know, or some of you may not know, the SACH-DNC, which stands for the Secretary's Advisory Committee for Heritable Disorders in Infants and Newborns, or it should be newborns and infants, huh? newborns and children, okay, has been eliminated. A couple months ago, it just was disbanded. The committee is no longer in existence. And that was the portal or the key to us as an organization or for a disease to get onto something called the RUSP, which is the Recommended Uniform Screening Panel. And once a disease gets put on the RUSP and goes through this process, the states are to look at the RUSP, and these are recommended diseases to put on their screening panels. But that is no longer in existence. Our newborn screening task force, which is made up of several people in this room, as well as a lot of other international collaborators, worked for several years on a nomination to submit it to this committee. And so we were pretty ready for submission until this happened. So we have a full application sitting in our computers. There was 2 other groups that were in the process of being reviewed when the committee was disbanded, and that was MLD and Duchenne muscular dystrophy. And so they are now currently in a stalled abyss, what's going to happen. So we're kind of watching them. We're friendly with them. We have a lot of connections. There is some political lobbying that's going on right now, and there's letters that are being sent to the secretary. Some of the groups may be hiring an expert to help advocate for them at a higher level. But the one thing about this is that it is providing opportunity. I know it's a very sad thing that this happened, but it's also going to give us an opportunity to make some changes to the way the system was beforehand, which was not really great. There was a lot of flaws in it. So maybe if it's paused or it's disbanded, something will resurrect and it'll be even better. So I'm an eternal optimist. I think about that all the time, and so I think there could be a silver lining to this, but not right now. So what we are doing as an organization is we want to educate our community about what's going on so that you can take action, because the only way, it's a collaborative effort. We as the organization and the leaders of the organization are doing the work, but we wouldn't be doing it if we didn't have collaboration from the patients, right? So we're a partnership. We are a patient-led organization, and that's a big term, right? Patient-led means we are being led by our constituents. And it's not led by a company or one individual or a couple people. It is patient-led. And so that will really help us in the future. So we're working on education. We're working on getting some materials together for legislators. And we're working on an outreach package. And we're also monitoring what's going on with MLD and Duchenne muscular dystrophy, just to see what's going on with them, and maybe we can follow in their footsteps. So that's the slide on federal newborn screening, which will now dovetail into our state program. So if we are not on the RUSP, and that has been stalled for now, we're going to pivot, and we're going to now go into each state, because the states are where the testing and the newborn screening is done. So we're very much in the early stages of development, because we were really focusing on the federal level. But now we're going to pivot. Our priority is to look at states with largest populations and ones that have CTX advocates or big volunteers for our organization. So those are the states that I listed up there that we have identified individuals who are going to help us get to state legislators in those states. If I'm missing a state and somebody is in here and wants to help, please let me know. So basically what we're going to do is we're going to develop a toolkit. We have lots of organizations that are doing this, that are advising us. We're kind of looking at their resources, maybe copying it a little bit. But you can see at bullet point number 4, I mean, we have so many resources at our fingertips that we can lead this process with a little help from our friends. The only thing about the state campaign, though, is that there's 50 states, right? So there's 50, I mean, it's not just one place that we're going. We're going to 50 different states. So it is going to be a long process. It is going to have to be a sustained process, and we're going to have to be really diligent about staying on top of things. So it's a big process, but we're ready for it, and that's our next step for newborn screening. Next slide. Our next big initiative, and a couple people talked about it, is we're going to Kyoto, Japan. The CTX Alliance is organizing an international meeting. It's dovetailing on our meeting that we had in Jerusalem. We want to make sure that we keep the momentum going and the engagement. We had 105 people at the meeting in Jerusalem in 2023. So it was huge for a rare disease. So we want to make sure we keep everybody involved. And there were people that were at the Jerusalem meeting that want to continue and be active within the organization, within CTX. So we're going to utilize this. We're bringing physicians, scientists, patients, advocates, and industry leaders. This is the day before the international meeting, ICIEM, the International Congress for Inborn Errors of Metabolism, close. And so we are now working with the Japanese conference planners. We have a room, we have a full day agenda, we have speakers, and we are inviting the Japanese leaders to come and also give us a talk about what CTX looks like in the Japanese culture. At this meeting, we have 3 main areas that we're going to focus on. About half of the meeting is going to be on developing a patient registry. And then the other half will be split between talks about developing a clinical severity score, which was heard in a couple talks today about how there's not a standardized scale for CTX, and then exploring the potential CTX carrier clinical manifestations. That was also addressed and touched on today. So those will be the 3 primary focused areas for this meeting. We will be recording the meeting, we will be taking notes, and we will make it available. It is not going to be virtual, so there is, getting that all organized would be very difficult. So it's not going to be virtual, but we'll be sharing information with you as the meeting comes up and then post-meeting. Next slide. The next thing, which is huge, is we now have a book, the first academic book on CTX, and it is titled A Treatable Rare Neurometabolic Disorder. This book is the culmination of a lot of work, a lot of efforts on our part. Basically, it is the chapters that were presented in Jerusalem. Those authors, or those people who presented it, converted their talks into chapters on CTX, and it has all been combined into this first ever book. It's going to focus on all these points that you see here. We've got included with the patient's perspective. We've got perspectives from all over the world. And it's available, I found out last night, on pre-order at Barnes & Noble. And it'll officially launch and be available on August 22nd, which is in a couple months. So you can see the authors on the book. It was an incredible journey to be a part of this. I've never put together a book or anything like it, so watching the whole process was really incredible, and it took a lot of effort. Next slide. We are now launching a CTX Awareness Day. So this is in conjunction with Mirum and their communications people. They've contacted us and said, hey, we know some other groups that have done something like this. I've done this in my past with other organizations, so we decided this was a really good idea. And the purpose really is twofold. The first purpose is to honor those who are affected and to recognize them and respect them and show the world that these patients exist. The second is to drive action and potentially talk about the symptoms and maybe find other patients who have not been identified yet. And what the concept is that it's going to be a matching volunteers who live in a state, and it helps that I have a state list now, right? So for the newborn screening, I'm also tapping into those other individuals, so it's twofold. But we have all the tools. Mirum helped me develop all the tools, and you're going to be able to submit a letter of request to your state asking for a proclamation, which is literally a piece of paper, or sometimes it's online. They don't even send them out anymore. But it says the state declares, or the state of Illinois declares September 17th as CTX Awareness Day 2025. And then we're going to do a social media campaign around these proclamations. Hopefully we get 10, 15 proclamations. I have the list. I know what order we need to ask for them and the timeline that it takes to get these documents. And we're hoping that everybody who gets them, we can take shots and screenshots and video, or we could take a picture, and we can do a whole campaign on September 17th. So that's our first inaugural year. We'll see how it goes, and hopefully we can gain some traction. Next slide. Okay, and so this is something that I did for a call a couple months ago, but I added more onto it. I think we formed in 2021, and we're now in 2025, and look at all of these milestones that this organization has done. So we formed in 2021. We got we did our patient PFDD in September of 2021. We got incorporated in October of 2021. We formed our MSAB in 2021. We had a conference here in June of 22. We attended October of 2022 the Global Leukodystrophy Initiative Consortium, also known as GLIA. We had a patient conference again in June of 23. We launched a global patient needs assessment survey to patients all around the world in 2023 July, and we used that data at our meeting in September 2023, which was the meeting in Jerusalem, which was the first ever scientific meeting for CTX internationally. In June of 2024, I went to Washington, D.C. and advocated for newborn screening with a group of colleagues from other organizations. We had our conference again last year here. We sent out a neuropsych survey in July of 2024, and then we had patients come on to, at the committee that just disbanded, we had patients that were able to come on and actually share their impact of CTX and newborn screening and why it was important in front of this whole committee and other volunteers. Now in February 2025, CDCA therapy was FDA approved, right? And now we have our first book being published, right? June of 2025, it's almost ready to be published. And then in June of this month as well, CTX has been added to the secondary findings list at the ACMG. So this is all in 4 years with a rare disease, a committed community, a committed group of leaders, and it's just amazing. And I'm very proud of the work we've done in it, and we look forward to doing more. Next slide. So here's my pitch, okay? So all this work takes money, right? We can't do it all for free. We have a ton of volunteers, but we do need to raise money as an organization. We are a 501c3 organization, which means you can make a donation to our organization and you're not getting any goods and services for it. It's a straight donation and you can write it off on your taxes. We've had seed funding for the organization from pharma and industry. But as an organization and being in this business for 30 years, we need to develop a diversified fundraising stream. We cannot rely on just one source of income. Otherwise, if that source of income goes away, what happens to us? We need to have multiple streams coming in so that if one ever goes down, we still have others to rely on, right? And that's something that the organization is really working on. So the essential next steps is to secure support from patients and families. We have not really reached out to patients, families, and stakeholders for personal donations. We've been relying heavily on pharma and industry. So I'm inviting all of you to join us in becoming a member of a monthly giving campaign. It's called GEM Club. GEM stands for Give Every Month. It is so simple and so easy, and it won't really be a major hit. It doesn't feel like you're giving money, right? It's $10 a month, let's just say. And you donate $10 a month through our recurring donation link, and then at the end of the year, you get a tax letter from me that will say, you donate $120. Now, if I came to you in December or the holidays, which is most of the time when people do fundraising at the end of the year, and ask you for a larger gift, you'd be like, well, that's gonna be a big hit because it's all coming at once. But think about it. You buy a cup of coffee, you drop $10 very quickly, right? You go shopping and you see something when you're waiting in line in Old Navy or whatever, and you're like, oh, I'll buy that, right? Just think about if you could just do that to CTX Alliance, and how much it would grow our organization. The best part about it is once you set it up, you can just set it up and then you're done. It'll automatically happen every month, and you won't even feel it, but we'll feel it because we really need your support. So next slide. Here is the QR code for those of you who are interested. I'm hoping that you can take a screenshot of that. It will take you right to our donate page. And if you can hit the slide one more time, right there is where you would click it, and it says monthly. And you could put in whatever amount you want. It could be $5. It could be $25. It could be $500. Whatever you want to do. You set that up, you put in your credit card, and it will our system is secure, and it will process it every month on the same day. All right, next slide. Okay, so any questions about the CTX Alliance, the work we're doing?
So you said pre-order the book, you did that online?
Yes, if you go to Barnes & Noble, you'll be able to search on it. It says CTX, or spell it out. Don't do CTX, do Cerebrotendinous xanthomatosis, and the book will come up.
Jean, I have a question.
Sure.
If somebody wants to try to work on a proclamation in their state, what is the easiest way to do it?
contact me and I'll give you all the links. There's going to be a page on our website where they can go to, and it'll have the link to send the letter and everything. Okay, so the next part of our program is something that's really exciting, right? We had a major milestone that happened for us this year, right? We had Ctexli is now FDA approved for patients with CTX, and that's a huge thank you to Miriam. We're going to do a group photo, but I'm going to turn it over to Andrea right now to recognize all those who are involved in this process.
So we have the slide here. I just want to reiterate what Jean said. We have so many achievements and celebrations for the CTX patients and the community in 2025. Next slide, please. As Jean put in a plug here, you can pre-order on Barnes & Noble the book, and this is the first ever book that really has all the experts in the field have written a chapter as they presented at the meeting. So this is a great achievement. Next slide, please.
That's the last one.
Yeah, keep going. We also have the ACMG secondary findings, which is a huge thing, I think. So this is great. Next slide, please. And I just, we spoke a little bit this afternoon about the difficulties in accessing treatment in CTX. And I'd like to thank Dr. Saute again for his very thoughtful presentation, but things are very positive here now in the US, but it wasn't always this way. So it's also been quite a struggle, to have access in the US. And I just, wanted to say, it's been mentioned today, the milestone New England Journal of Medicine treatment with CDCA study in 1984 with Dr. Bergener and Salin and colleagues with that study. And so, at that point, chenodeoxycholic acid was approved for use in gallstones by the FDA. And even though it was approved, kind of fast forward the next couple of decades to the end of the 2000, around 2009, even though it was approved by the FDA for treatment of gallstones, it wasn't actually available in the US. So it being a rare disease population and not having enough patients, there were no companies that really wanted to produce it. And I know in speaking to many of the patients here, that was a very difficult time. You had to order from Germany and out of the country, and it wasn't available. And so, I wanted to say, we are so grateful to the United Leukodystrophy Foundation because Paulo Brazil at that time really impressed on the FDA the importance of providing an orphan drug designation for Chenodal. And with that orphan drug designation, Manchester Pharmaceuticals then actually started manufacturing and marketing CDCA and made it available in the US again. So, this is the letter that the ULF sent out at that time. And again, they were very instrumental in getting the orphan drug designation and making sure that the patients in the US had access to CDCA again. But of course, this was still with the approval for gallstones, not to actually treat CTX. And so, next slide, please. So fast forward now to the RESTORE study, that we've discussed a number of times today. And the results for this landmark RESTORE study, next slide, please, led to the FDA approval. And so this is a huge milestone for the community that we would really like to recognise everyone who was involved in this tremendous work of the RESTORE study. It really was a multi-year project. We started this process, back more than 5 years ago. It wouldn't have been possible without the patients that participated in the trial, all of the physicians and co-authors on this study, on the RESTORE study that worked so hard. I know my lab are watching remotely. I want to thank my lab again because they worked so hard for the biomarker data for the RESTORE study. But also, we'd really like to thank the sponsors because, I work with them closely. My colleagues at Trevere and then Miriam, I've seen how hard they worked on this as well. And to take this through, it was a long 5-year study. to push it over the finish line and to get approval for treatment in CTX is huge and huge for the community. And now hopefully that will make it accessible so it's not difficult. And so with that, we would like everyone to go back and grab a glass of champagne, and then we can bring it here for the photo opportunity.
Okay, ready? On the count of 3. Oh, you did. Okay. Yeah, ready? All right, 1, 2, 3. Cheers! Thank you. All right.